Is it changing?
Hey, it's going.
Yes.
Fantastic. Okay.
Well done.
So like I said, this is a paper you can look at that was published in SAMA quite a while ago by Liesel Andrach, one of our colleagues, on pattern recognition in pediatric ECGs. There's this resource in the emergency medical clinics of North America on pediatric ECG. This paper is specifically on fetal and neonatal arrhythmias, also from the Academy of Pediatrics. And this is a nice paper that looks at the asymptomatic teenager with what is reported as an abnormal ECG, but what might actually be normal for a teenager. Then there's this app from UCT that you can get on the Google and on the App Store. It's quite nice. It's free, and it's nice if you want to go through a couple of ECGs in your own time. You can also go to CASA's website, and we've held previous webinars, ECG webinars, actually several, and it was mostly aimed at, well, it was aimed at GPs and physicians, but there will be a lot that will be of information for you as well if you want to explore more ECGs. So when we look at pediatric ECG interpretation, it's important to remember that there are age-related evolutionary changes that we see on the ECG. So you need to keep that in mind. Luckily, though, we see a limited number of typical ECG patterns in pediatrics, so pattern recognition will help. Fetal circulation relies on the right side of the heart, and then with increased physiological stress and increased load of work, you'll find that the left ventricle would become more dominant, and this will be reflected on the changes that you'll see on the ECG. So also when we look at the ECG, it's important to remember both the anatomy and the conduction system. The RV is anterior to the LV, and like I said, dominant in newborns and infants. Then with age, the LV becomes more dominant, and by adolescence, it's 2.5 times as thick as the RV, and you'll see that will explain some of the changes you see on the ECG. You all know this, but the P wave looks at atrial depolarization. The QRS complex is ventricular depolarization. T wave is repolarization of the ventricle. And then when we interpret the ECG, it's important that you have a systematic approach and that you use this with every ECG you look at. Avoid to make a snap diagnosis. Use everything, look at every complex on the rhythm strip on the ECG and look at the rate, the rhythm, the axis, the intervals, your P waves, QRS progression, ST segments, T waves, Q waves, and then a few extra things that we'll look into as well. So what is the correct placement of the ECG electrodes? It's important that we make sure that it is placed in the 5th intercostal space, the precordial leads, not too high or not too low, because it will affect your interpretation if it's placed incorrectly. There are certain situations where we might place lead V1 and V2 higher, but if you, for standard ECG, 5th intercostal space, so the middle block there, B, is the correct placing of ECG electrodes. So when we look at the ECG recording, the ECG machine uses your electrodes, and then the ECG recorder uses Wilson's central terminal, which is a virtual reference area that's used as reference. And if you look at the bottom there, you can see that where the vectors are positioned from V1 to V6, if it's positioned correctly, as I showed you there. And if the conduction is positive, it means that it's in the direction of the electrode, going towards the electrode. And if the deflection on the ECG is negative, it means that the conduction is away from the electrode. So that helps you understand the changes you might see on the ECG. So also remember that the ECG machines are calibrated with adult values, but it is used, and you have to check that this is correct before you make any interpretation, especially when it comes to voltage criteria for ventricular or chamber enlargement. and also when you measure your intervals. So on the ECG machine, you will see where it should show you the settings, and also always check the standard setting is 1 millivolt, is 10 millimeters, and one small block will be 0.4 seconds or 40 milliseconds, and one big block is 0.2 seconds or 200 milliseconds. And you need to make sure that that's correct. Then if we look at what we see on the ECG, so it's the P wave, the QRS, in between the PR interval. Now you measure the QRS duration, where you might see a J wave. Then it's followed by the T wave. You might see a small U wave that follows that. And how we measure the RR interval. So all of these intervals you also need to evaluate on every ECG. So when we start with ECG interpretation, obviously the first thing is make sure that you've got the right patients, the right date, that your settings are correct. Then the next thing we look at is at the rate. So cardiac output in children, as you know, is primarily determined by the rate. And as you age, the ventricles mature and the stroke volume improves, so your heart rate decreases. So if you want to calculate the rate of ventricular rate on the ECG, you can use the number of QRS complexes in the rhythm strip in the 12-lead ECG and multiply that by 6, so that's over a 10-second recording. Or you can use the number of QRS complexes and divide it by the number, or divided by the number of the large squares between the two sequential, sorry, that's wrong, it's 300 divided by the number of large squares between two sequential R waves. So I'll show you an example there. So if we look at the top, you count 12, so it's slightly irregular. So then you can't just use the number of blocks between the R waves to decide what your rate is. But if you count, you've got 12 complexes, times that by 6, that gives you a rate of 72, and the same with the ones at the bottom. Then it's important to remember, like I said, there are age-related normal values. We can make this available to you afterwards. So it's important that you do make sure that you use the correct reference, and when you look at a correct reference for the child's age. Then we look at the rhythm, and for rhythm, we want to look at the P wave axis, the relationship to the QRS complex, and the P wave morphology, because we can have an atrial rhythm, which can be from sinus, the coronary sinus. You might have changes in the P wave morphology with the wandering atrial pacemaker, or atrial ectopic tachycardia. You can have a junctional rhythm, a ventricular rhythm, and heart block. But I'll show you examples of that later. So first we look at the rate, then we look at the rhythm. And when we look at the rhythm, we want to know, is it regular? Is it irregular, but with a grouped beating? For example, the second strip where we've got a ventricular bigeminy. Or is it group beating with a set relationship between A's and V's? So you count the number of A's, the number of V's. Are there more A's than V's, more V's than A's? And you look at the relationship between the P wave and the QRS complex. So again, when we get regularity, it can be intermittent in an otherwise regular rhythm, like the top strip, which could be due to pauses, or you can have irregular rhythm at the bottom where there's no specific pattern to it, like we see in atrial fibrillation. When we look at the QRS complexes, we want to measure the QRS duration, progression, look at the morphology, look at chamber enlargement, and we want to know, are the QRS complexes narrow or broad? And it's best to evaluate the QRS complexes in the chest leads, so V1 to V6. And those values of 100 and more than 120 is in adults. And if you want to interpret in children, again, you need to look at the age-related changes in that table that I showed you. So when we look at ventricular conduction disturbances, when there's abnormal conduction through the ventricular tissue, you will have a prolonged QRS duration. This is an example of what the right bundle branch block may look like. I think you all remember it's the easiest way to remember is it is marrow, so a M shape in V1 and a W type shape with a broad and deep S wave in V6. And that indicates that there's delayed conduction through the right bundle with delayed depolarization of the right ventricle. And we can see this after in patients who had a right ventriculotomy, patients with the ASD, certain systemic diseases, and it can also be found when you've got ventricular pre-excitation with a left-sided accessory pathway. Then as opposed to that left bundle branch block, it's rare in children, but you've got the reverse where you've got a deep S wave in V1 and a broad R wave in V6, giving you more a pattern of the William pattern with a W in V1 and an M in V6. This is very rare in children, but you can see it in children with cardiomyopathy or systemic heart disease or ischemic heart disease due to abnormal coronary arteries, for example, or in WPW with a right-sided accessory pathway. When we look for chamber hypertrophy, so again, showing you on the right side what a normal leads look, precordial leads look like. Again, we look at V1, V2, V5, and V6. In right ventricular hypertrophy, you'll have an R wave predominant in V1 and a big S wave in V6. You might have an RSR pattern, like you see there at the bottom right, in V1. And again, you need to remember what the age-related values are. One of the easiest ways to see whether there's right ventricular hypertrophy is if you've got upright T waves in V1 after the first week of age. Because the T waves are upright in the neonate in the first week of age, then they invert and they only become upright again by teenage years. So if you've got an upright T wave in V1, that's very suggestive of right ventricular hypertrophy. The same for Q waves in lead 1, V1. Left ventricular hypertrophy, you'll have a left axis deviation, a prominent R wave in V6, and a deep S wave in V1, like the middle bit there. You might also see deep Q waves in V5 and V6, and you could see a strain pattern where the T wave to the QRS axis is more than 90, so that might be with inverted T waves. Then there's a phenomena called Katz-Wachtel phenomena, where you've got equiphasic QRS complexes in 2 or more limb leads and in the mid-precordial leads. And if you can see there in V2, V3, where I don't know why my arrow, I don't see can't point. Anyway, so where the complexes are equiphasic in V3 and V2. Indicating that there's biventricular hypertrophy, so both the right and the left ventricles enlarged. Then next we look at the QRS axis. There are different ways of using it, but I find the easiest is to use lead 1 and lead AVF, where lead 1 is positive towards the right, negative to the left. AVF is positive if the vector points inferior, and negative if the vector points up superior. So then you can see what we call a northwest axis, a left axis, a normal axis, and a right axis. But remember again that you might see a right axis in children and infants, and it could still be normal. And as they age and grow, the axis changes to what is considered to be normal in adults. Again, there's that table that you can look at to help you decide whether there's an abnormal QRS axis. So there are some conditions that can cause right axis in asymptomatic children. So it could be a normal variant, but it could also be due to conditions like right ventricular hypertrophy, dextrocardia, you've got pulmonary disease, pre-excitation, or atrial septal defects. A left axis deviation is very rare in healthy children. You might get it if you've got conduction disturbances, so left bundle branch block or a left anterior Remy block. It's mostly associated with heart disease, so left ventricular hypertrophy, pre-excitation, or congenital heart defects. Especially if you've got a northwest axis. Remember that block that we looked at? If it's in the left superior, that's the indication of one of those conditions, generally speaking. So it could be a AVSD, tricuspid atresia, TGA, a single ventricle, or a double outlet right ventricle. So that's definitely abnormal if you've got a northwest axis. I think generally speaking, if you've got a left axis deviation and a left bundle branch block in the child, it's worth investigating. If you've got a right axis and a right bundle branch block, or specifically an incomplete right bundle branch block, then I don't think that's necessarily something to be worried about. So if we look at the P waves, we again want to look at the rate. We want to look at the P wave axis and then the P wave morphology. And of course, the relationship of the P waves to the QRS complexes. So you calculate the rate the same as you would for the ventricular rhythm, the number of complexes in the rhythm strip times 6. And then we look at the P wave axis. If we've got sinus rhythm, like is shown there on that little cartoon at the top, you will have a positive P wave in lead 1 and lead AVF, and also and lead 2, so the inferior leads, and it will be negative in AVR. So that indicates, remember, if we think back to that picture of where the vectors point, so from that you can see that the conduction is going away from the right side of the heart, from superior to inferior, and that indicates that it's likely a sinus rhythm or somewhere near the sinus node. And again, that's important if you've got ectopic atrial tachycardia or a wandering atrial pacemaker, then you will see that there are changes in the P wave morphology and quite likely the P wave axis. Then we also look at the size of the P waves. A P mitrale is a prominent P wave with more than 2 small blocks in neonates and 3 small blocks in adolescents. And that is a sign of left atrial hypertrophy. And the P pulmonale are bigger P waves, peaked P waves, more than 3 small blocks in adolescents. And that is an indication of right atrial hypertrophy. Then we look at the relationship to the QRS complex. So we want to know, first of all, are there more Ps than QRS complexes? Are there more QRS complexes than P waves? And then we look at the relationship or the PR interval between the P wave, the onset of the P wave to the onset of the QRS complex. And looking at the ST segments, so T waves are upright in V1 in the first week of life, then thereafter they invert, and then again by between 8 years to early teenage years, they are upright again. So if you've got the upright T wave in V1 in between that period, then like I said, that's a sensitive marker for right ventricular hypertrophy. We might also see that the juvenile T wave pattern may persist after the age of 6 to 8 years. So it's not uncommon to see that in pre-teens or early teens. And you might also see evolutionary changes in the T wave where it is inverted and then biphasic before it becomes upright. Early repolarization is a normal or could be a normal variant. And then we'll look at the T wave or QRS axis again. And if the axis is more than 90 degrees, that is an indication that there's a strain pattern. And then there are causes for ST elevation or depression. So on the left there is normal ST segment, depressed and elevated. And those are the possible causes that you need to look for when you see this. Next, we look at the QT interval. So the best lead to measure the QT interval is in lead 2 or lead V5. So you measure from the beginning of the QRS to the end of the T wave. And the best way to do that is to draw a line, a tangent line with the slope of the T wave. And where that crosses the baseline, that's where your T wave ends. You can see on the little cartoon there. We most commonly use Bassett's formula to calculate the QTC, which is the QT divided by the square root of the RR. You can't use a Holter ECG. Those measurements aren't accurate or cannot be relied to make the diagnosis of long QT syndrome. And then the QT interval is usually longer in the first 6 months of lives, and after that they return to what we see in adults. So important, lead 2, lead V5, wherever you see the T wave the best. So when we look at the QT interval in neonates, I follow this as a guide because, like I said, we see a slightly prolonged QT interval quite often in the newborn. If I see a QTC that's greater than 485 milliseconds, I think you can be fairly sure of the diagnosis of long QT syndrome. And if available, I would offer genetic testing to those patients. If the QTC is between 460 and 485, we do an ECG on both parents to screen for long QT, as long QT syndrome is normally autosomal dominant, and then follow that baby. And by the age of 1, the majority of cases, the QT will have normalized. If the QTC remains greater than 460 by 1 year of age, then you've got which we see in about 25% of cases, you've got a 90% chance of having a long QT causing mutation. Okay, then next we look for Q waves. So Q waves are caused by the depolarization of the interventricular septum, and it's always from the embryological left to right ventricle. So it's important to see if you've got Q waves in lead V5, V6, that's considered normal. But if you've got dextrocardia, you might find that the Q waves are in lead V1, V2 instead of V5, V6. You can have normal Q waves in lead 1, 2, 3, AVF, V5, and V6, like I've shown in the top picture there. Abnormal Q waves would be if they are more than 0.03 seconds or more than 5 millimeters deep. Deep Q waves can be seen in a small percentage of children, especially in healthy athletes, but it must make you think that either the leads could be misplaced, could have chamber hypertrophy, there could be pre-excitation or pulmonary disease. So at the bottom, we've got examples of abnormal Q waves. We can see that they are longer in duration and they are much deeper than the ones in the top picture. Then we look for extra beats. So PVCs are very common. On a routine ECG, you might find in up to 2.2% of children, you might have premature ventricular contractions. And if you do a Holter ECG, it's even more prevalent. So if the PVCs are benign, isolated, you've got a structurally normal heart, and they are suppressed on exercise, then it's likely not anything to be concerned about. If you do see PVCs outside of that, though, or there's a family history that's concerning of syncope or sudden cardiac death, then that would be a reason to refer for further investigation. Premature atrial contractions are even more common at all ages. Might often see that on a resting ECG, and it's extremely common when you do a Holter ECG. And as you can see, similar with the PVCs, where you get the extra, and then there's a compensatory pause before the next sinus beat. We see the same thing with premature atrial contractions. We've got a sinus beat, then the extra beat, a compensatory pause, and then a sinus beat again. And if you pay close attention to the P wave morphology on that rhythm strip, you'll see that every extra beat, the P wave morphology is slightly different than what we see during sinus beats. So when you look at a normal ECG, variants that you might find in young children and adolescents that are unlikely to indicate that there's any heart disease is a sinus arrhythmia, sinus bradycardia, first-degree heart block, a Wenckebach, and I'll show you examples of that later, especially in fit, healthy people or young children with high vagal tone. And if you do a Holter ECG, you often might see that at night when they are asleep and their vagal tone is higher. Incomplete right bundle branch block, especially if there's no right ventricular hypertrophy and you've got a normal axis on the ECG. Early repolarization and a right axis deviation in a child 8 years or younger, and juvenile pattern of repolarization, so the persistent T wave changes that we spoke about. So these findings are likely normal, unlikely to be associated with any cardiac disease, especially if the rest of your systemic examination is normal and there's no history of concern. So this is important, I think, to remember what would then be an abnormal ECG when you need to refer. So if you've got criteria for chamber enlargement or hypertrophy of any of the chambers, a left axis deviation, definitely. If you've got an abnormal rhythm, other than sinus rhythm, sinus bradycardia. If you've got frequent ectopic beats, especially ventricular ectopic beats associated with a concerning family history or a history of syncope or abnormal examination. If you've got a left bundle branch block, that's usually abnormal in a child. If you see a right bundle branch block and the QRS axis is also deviated, heart block, you see second degree type 2 Mobitz 2 heart block, and I'll show you examples of that as well later. Of course, complete or third degree heart block. If you see Wolff Parkinson White, ventricular pre-excitation, or if you're concerned about abnormalities in the repolarization pattern, or an abnormal QT interval. So if you see any of these patients need to be referred. So do you want to take a 5-minute break, or are you okay to carry on?
I think they are strong, Adele.
Okay.
What do you think, Janelle?
I've got my travel mug with coffee, so we can carry on.
Sounds good. I'm sure we can go ahead.
Okay, so this was the more boring bit. So hopefully the next bit you'll find a bit more interesting when we look at examples. So the next part of the talk will be interactive. So please vote. Like we said, we're not going to know who voted what, and it just makes it more interesting for everyone. So this is a 6-year-old girl that was found to have an irregular heartbeat on examination at the pediatrician's office. This is the ECG they did. And now my first question to you, is this a normal or an abnormal ECG?
Okay, well done. We've got about 40 people that's voted. Get your
Okay,
votes in there.
This is the easy one. You should all vote on this one. You've got a 50% chance of being correct.
Okay, we're going to give it just a few more seconds. Okay, great. So about 2/3 of the people have voted.
Come
So
on,
I
guys,
think I'm
this is
going
the
to
one you
end the
should
poll.
Should-
Okay, let's end it. You can tell me if I can share the results,
Yeah,
Adele.
share.
Okay, good. Let's share. Can you guys see that?
Okay, fantastic. That's a great start. 72% of you think that this is a normal ECG, and only 28% thinks it's abnormal. So what would you do next? Would you call an ambulance? Would you refer the child to the pediatric cardiologist at the next available appointment? Would you reassure them and send them home? Or would you do electrolytes and thyroid function tests?
Hey, well done. So we've got about 70 votes. Wow, the people are good with this one. They know the answer now.
Right.
Okay, so just a couple more seconds and then we'll end it. Okay, guys, get your votes in. Okay, I'm going to end the poll. You tell me when I can share the results.
Yeah, good share. Okay, again, fantastic. No one wants to phone an ambulance. That's great. And 77% of you said that you would reassure them and send them home. 5% would still refer to a cardiologist, and about 18% said that they would do electrolytes and thyroid function tests. Okay, so this is in fact sinus arrhythmia and a normal ECG. And again, if you use everything we've talked about so far, you see the rate is normal at 12 times 6 complexes, so it's a rate of 72. It's slightly irregular. We look at the P waves, upright in V1, positive, upright in lead 1, V1, positive in the inferior leads, 2 and AVF, negative in AVR. So this is likely comes from the SA node. It's a sinus rhythm. The QRS duration is normal. QRS is not broad, not prolonged. Normal QRS progression. No signs of chamber hypertrophy. ST segments look fine. QT interval is normal. So this is a normal ECG and sinus arrhythmia, which is very common in children and not a cause for concern. Sometimes you might find that it's even more pronounced with longer pauses. And this also changes with respiration. So you might see respiratory changes, slowing and quickening of the heartbeat during respiration. But it's completely normal. You don't need to do any further investigations. You can send them home and reassure them. Okay, so reassure and send them home is the correct answer. Right, let's look at the next one. So this is a baby in neonatal ICU, and you are called to see the baby because the obstetrician noted a slow heart rate. Give you a bit of time to look at the ECG. Well, this is a rhythm strip. They've only, as often happens, no one's done an ECG and they show you the rhythm strip on the monitor.
Yeah.
So the question is, what's the diagnosis? Is this sinus bradycardia? Is it Mobitz 1 heart block, Mobitz 2 heart block, or complete heart block? If you want, I can put, then I can't put the ECG back while the poll is running. We'll give you some time to vote.
We've got about 50% people. So I think for the next one, I'll maybe leave it on the ECG and then I will launch the poll
Yeah,
on
I
the,
think we can show the questions and I'll go back to the ECG and then you
and
launch
then
it.
I'll share it. Yeah, sorry. Great.
No, it's okay. I also didn't know that I can't go back once you've shared the poll.
Okay, great. So we've got about 60% that's voted. So I'm going to end the poll.
Let's see.
It's a very equal, a
Right.
quarter of
Sure.
everything.
Yeah. So seems I got you with this one. It's split in 4. Okay. So let's have a look at it. So I agree, it is slow. It is a bradycardia. Then next we need to look at still a narrow complex. Don't think it's broad QRS complex. We need to look at the number of P waves to the number of QRS complexes and the relationship of the P waves to the QRS complexes. So I think if we start, it's a regular rhythm. So if we look, there's a QRS, 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 right? Regular, slow, narrow complex. There we see, now if you plot out the P waves, there you can see a P wave. There's a P wave, and a P wave, and a P wave. So there's a regular atrial rhythm, a regular ventricular rhythm, more A's than B's. So we've got a type of heart block here. It's definitely not sinus bradycardia. Now, to decide what heart block we've got, we need to look at the relationship between the P waves and the QRS complex. And if you follow it closely, especially if you look at the bottom of the slide, you'll see that there's no relationship between the P waves and the QRS complexes. There's no PR interval isn't fixed. It's not gradually prolonging. There's absolutely no relationship between the A's and the B's. So this is in fact complete heart block with a narrow ventricular escape. Okay. So first degree heart block is when we just have prolongation of the PR interval, generally over 200 milliseconds. But again, remember, you need to look at the age specific values. So there you can see there's a fixed relationship between the P waves and the QRS complexes. If you measure it, it's exactly the same duration for every beat. So that's first degree heart block. This normally can be normal, doesn't necessarily need further investigation. But if you see it in a child where you're worried on examination, or there's a history, for example, say where you're concerned about rheumatic fever, then that would be a reason to refer. First degree heart block. So second degree heart block, Mobitz 1 or Wenckebach heart block. If you look at it, we still have at the beginning of the strip, there's A, V, A, V, A, V, and then we see a dropped QRS complex. So there's an A without a QRS. So that beat blocked. And if you measure the squares, and often you need to plot it out, use a piece of paper and mark your P waves and your QRS complexes a couple in succession, and then move it along your rhythm strip to see if there's a change, because it can be quite subtle. But there you can see we start with 4 small squares, then we've got 6 small squares, 7 small squares, and then a drop beat. So that means that the PR interval gradually increased, and that is most likely normal. It's a physiological phenomena. Mobitz type 1 heart block, you don't need to worry about this, doesn't need investigation, doesn't need any treatment if asymptomatic. So here we've got Mobitz type 2 heart block, second degree heart block. Again, at the beginning of the strip, we've got a P wave QRS complex, P wave QRS complex, P QRS, then a P where it's dropped, a drop beat. There's no QRS complex. And then following that, again, P QRS, and then a dropped QRS complex again. So if you look at there's again more A's than B's, so there has to be a form of heart block. And if you here measure out the PR interval, you'll see that the PR interval is fixed. So there's no prolongation of the PR interval before we get a drop beat. And this is Mobitz type 2 heart block. It's high degree AV block. This is abnormal, and this needs to be investigated, and this needs to be referred. Okay, so the relationship between the P and the QRS. And then this is like the one I showed you, just more pronounced. But again, there's no relationship between the P's and the QRS complexes. And this is a wide QRS, wide ventricular escape. So this also is abnormal and needs to be referred. Okay, so that's a couple of examples of slow rhythms in pediatrics. Now if we look at tachyarrhythmias in children, most commonly, we see supraventricular tachycardia. So supraventricular means that the origin of the abnormal rhythm is above the AV node. So that actually incorporates, when we talk about SVTs, we normally generally refer to the re-entry tachyarrhythmias, but it could be sinus tachycardia, could be a ectopic atrial tachycardia, atrial flutter or atrial fibrillation, AV reentrant AVRT with the accessory pathway or Wolff-Parkinson-White type syndrome, or it could be AV nodal reentry tachycardia where the reentry circuit is within the AV node. So those are all classified as supraventricular tachycardias, or it could be ventricular. Luckily, ventricular arrhythmias are very rare in pediatrics. SVT is the most common in infants, and again, there's age-related changes. In infants, 80% of the time, it's going to be a AVRT, so accessory pathway. And then as they age, by about 5 years of age, the prevalence and distribution is about the same as we see in adults, with still about 60% AVRT or accessory pathways, but AV-NRT and atrial tachycardias become more common then. The other types of arrhythmias are more infrequent. AF is very rare, unless it's associated, and if you see AF in a child, it's usually associated with manifest pre-excitation or WPW. We'll have a look at that in a bit as well. So SVT incidence, it peaks in the first 2 months of life. Then about 60% of children by the age of 1, it will resolve. 30% will then have a recurrence by the age of 7 to 8 years. But in about 40% of cases, even if it is with an accessory pathway, you will lose manifest pre-excitation. So you won't be able to see the accessory pathway on the 12-lead ECG. You might just have concealed conduction, but they could still have SVTs. If you see a child at the age of 5 and they have a SVT or even asymptomatic pre-excitation on ECG, it's unlikely that that's going to resolve by itself. So that would be a reason also to intervene and to evaluate and refer. I'll tell you a bit more about that later. So the presentation and the natural history, most SVTs aren't life-threatening. In the odd instance, it might lead to hemodynamic collapse or tachycardiomyopathy. And there is a risk of sudden cardiac death, albeit low, associated with pre-excitation or Wolff-Parkinson-White. And that is thought to be due to rapid conduction over the accessory pathway when patients have AF, which then leads to ventricular fibrillation. So again, it's rare, but it can happen. So the presentation can be very non-specific in infants, but generally if you have a heart rate over 220, that's persistent over 220, it's abnormal. In older children, they might complain of chest pain, dizziness, palpitations, syncope. Generally, if you do an ECG, you'll have narrow QRS complexes, and you might struggle to see P waves, and there might be no beat-to-beat variability. You may need further investigations to aid your diagnosis, but if you can, always try to get a 12-lead ECG during the episode. So then when we look at tachyarrhythmias, when we decide what it is, I always follow this. First you decide, is it regular or irregular? And then we decide, have we got a narrow or a wide QRS complex? So it can be regular and a narrow QRS, or regular with a wide QRS, irregular with a narrow or QRS, or irregular with a wide QRS. Then you can further break that down into what you might commonly see in those blocks. So if you've got a regular narrow QRS, a tachycardia, that's what we most commonly will see in the pediatric population. It could be a sinus tachycardia, the re-entry tachycardias, AVRT, AV-NRT, atrial tachycardia, or a junctional ectopic tachycardia. If it's regular and wide, if you see any wide QRS complex tachycardia, it's safer to assume that it's VT and treat as such until you can confirm the diagnosis. But you could have SVT with a bundle branch block. Could be an antidromic AVRT, which I'll show you an example of as well, or other SVT with accessory pathway, pre-excited SVT. If it's wide and irregular, again, I'll show you examples of what we need to look for. But like I say, if you see a wide QRS complex tachycardia in a patient without a previous diagnosis, or you're unsure, it's safer to treat it as a VT and then look at the diagnosis afterwards. So because this is emergency, the topic was emergencies, I'm just going to go quickly over this. I think, Mamaila, I don't know if you are going into the treatment of SVTs in your talk, so we'll do this quickly. But if you do see a narrow QRS regular tachycardia, I think it's likely a SVT. The acute management, of course, if the baby is or the child is hemodynamically compromised and shocked, then you cardiovert. Don't then first try and get the ECG or do any other maneuvers. You just electrically cardiovert. But if not, and the patient is stable, then please try and get a 12-lead ECG before commencing any treatment. So first of all, we'll try with vagal stimulation, which could be the dive reflex, a cold cloth or ice water cloth on the face and the forehead. You can try vagal maneuvers to first see if you can terminate the SVT. Also, when you do this, please try and have a rhythm strip running because it can help with the diagnosis. If that fails, next you'll give adenosine. And when you do that, it's important to do it correctly. So you have a three-way tap, your syringe with the adenosine, and then a bigger flush syringe with 20 ml saline, for example. And you give the adenosine and then rapidly turn the three-way tap and flush it. Adenosine has got a very short half-life, so you need to do this quickly. Otherwise, you will think that it hasn't worked, but it's just because it's actually it took too long to administer the flush. So what can happen if you give adenosine and you give it correctly and the correct dose? Well, you might have no effect, and that could be due to an inadequate dose or delivery. That's most often what we see. Or you could see that there's gradual slowing, then reacceleration of the rate. So if you look at the ECG at the bottom, you can see that it slows down, but nothing much changes. There's no VA dissociation even. And then it speeds up again. So that we'll see if it's a sinus tachycardia or an atrial tachycardia, or the bottom right, a junctional ectopic tachycardia, where when you give the adenosine, you can see there's a QRS P wave, QRS P wave, give adenosine, then you see QRS complexes without the P wave. So there's AV dissociation. So you know that the rhythm is not dependent on the atrium, and that's a jet. So you might also see sudden termination. So if it terminates, then you know that the AV node is part of the circuit most of the times. So AV-NRT or AVRT would be the most likely diagnosis. But as you see at the bottom strip, that's why it's important to have the rhythm strip running. Because if you gave adenosine there and you didn't have an ECG running, you would say, oh, the adenosine didn't work. There was no response because the tachycardia didn't terminate. When in fact it did terminate and then just initiated within a couple of seconds. And we get a lot of important information from that rhythm strip. So please try and have a rhythm strip running.
Adele, can I quickly ask
Yeah.
you? Some people are asking you're going a little bit fast through the ECGs.
Okay.
And I don't know if your pointer is showing when you...
No, I can't. My pointer
Okay,
is not.
I'll see if I can set that up on the back end quickly.
Okay.
Yeah, so some people are just asking just to go a little bit slower if you show the actual ECG.
Okay, I can do that. I don't know how to get the pointer to work.
Okay, I'll see if I can fix it
I think
at the
it
back
worked
end.
when we did the trial run, but
Yes.
I can't do that now.
Okay, perfect. Thank you.
Okay, sure. So you might also give adenosine, and then the tachycardia persists, and there's slowing of the ventricular rate, but the background tachycardia is unmasked, like we see here, and that we'll see with a focal atrial tachycardia, or if there's atrial flutter or other reentrant tachycardia. If you can see at the top there, where the adenosine is given, there's a QRS, then P waves, a couple of P waves, QRS again. There's no association between the two, but you can unmask the underlying rhythm in the back. And again, this is a nice example of a patient in flutter, where at the beginning of the ECG there, it's very fast, flutter with 1-to-1 conduction. You give adenosine, the AV node blocks, and then it nicely unmasks the sinus, the sawtooth pattern of atrial flutter, enlarged on the right. Okay, so if adenosine doesn't work, when not to give adenosine, if you see this ECG, I'm going to show you next, we're going to look at it again later, but it's a fast, broad, irregular ECG. This is one of the true electrophysiological emergencies in pediatric cardiology. This is pre-excited atrial fibrillation. So it's a patient with an accessory pathway and AF and rapid conduction over the accessory pathway. And if you give adenosine and you block the AV node and potentiate conduction over the accessory pathway, you might get VF, as is shown in that strip here. So this is when you don't give adenosine. Okay, medical management, I don't think we should spend too much time on this because I want to show you more ECGs, but we've got limited drugs available. We've got flecainide, propranolol, beta blockers, amiodarone, and digoxin, and all of them with varying chances of success at suppressing the SVT. Complications are common or can be common with drug over and underdose, and then ablation is possible and it is safe. Risk stratification in patients with WPW, so pre-excitation, but no tachycardia reported. If the child is over the age of 5, then I would still recommend that they be referred for invasive risk stratification to decide whether this is a pathway that needs to be ablated, because there is a small risk of sudden cardiac death being the first presentation, even with asymptomatic pre-excitation. Okay, I mean, we can make this available as a PDF, and then people can go through the slides again afterwards.
Adele, can I interrupt you for 1 second?
Yes.
There's a question online from Tiamo Mafora, just
Yeah.
before we get too far away from the heart blocks. It says, with regards to heart blocks, especially differentiating the second-degree Mobitz type 2 and complete heart blocks, when do we consider the fixed ratios?
So with complete heart block, there will be no relationship between the QRS complexes. So this is second degree, Mobitz 1, sorry. So Mobitz 2, can you see that there are more A's than V's, but the timing between the A and the V remains the same until there's a drop beat. So the first 3 beats, the timing, the red blocks, it's exactly the same number of blocks. And then the fourth atrial complex, there's a dropped QRS. Okay, so that's Mobitz 2. And with complete heart block, there's no relationship between the P waves and the QRS. So the QRS complexes are marching through at their own regular rhythm and rate, and the P waves are often also at a regular rate, but there's no relationship between the two. Does that make sense?
Luzuko, do you maybe want to add something? I see your hand is up. Yeah, I think it might be accidental.
Adele, can I just, while we're there as well, there's one more question from Aisha Khan about SVTs.
Yes.
In adults, they use lignocaine for SVT. Is there an option in pediatric patients?
Actually, no. In adults, we also don't really use lignocaine for SVTs. So, no. It's not in any of the guidelines, adult, pediatric, anyway, in the acute management of SVTs.
Thank you.
Okay. Right. So this is a newborn baby that was born with eye drops. And this is the ECG you get after delivery. I'm going to show you the questions and then we'll come back to this.
Adele, apologies, I'm going to be a little rude. There is another request for you to please revise the slide. You know, you showed the ECG of when not to give adenosine.
Yes.
Niri Naidu is asking, can you please just show that slide again and just explain when not to give adenosine, please, if you don't mind?
Okay.
Everyone is very awake this time of the morning. They're all
Yes.
looking carefully at all your slides.
Glad people are listening. Okay. So this is a fast, broad QRS and irregular tachycardia. Do you all agree with that? I still can't use my pointer, but can you all see that? The QRS complexes are broad It's very fast and it's irregular. So this means that this is a typical ECG for pre-excited atrial fibrillation. And like I said, this is a true EP emergency. If you see this, you don't give adenosine, because so the mechanism of the tachycardia here is atrial fibrillation. You've got atrial fibrillation in the background with conduction over the AV node and the accessory pathway. If you can see at the bottom, the rhythm strip at the bottom, you'll see there are complexes that are broader than others, and some are a little bit more narrow. And there in the middle third of the screen, you see a QRS that actually looks fairly normal. So there's atrial fibrillation in the background with a combination of conduction over the AV node and over the accessory pathway. Okay? Does everyone, do you understand? Do you understand that? So if we give adenosine, adenosine blocks the AV node. So now we might get more rapid, we might get more rapid conduction of the atrial fibrillation over the accessory pathway only. So now you have very, very fast conduction to the ventricle at the rate there of, if you look at that, that's 300 plus. So that is enough to then destabilize the ventricle and cause ventricular fibrillation. Okay, so it's because of the atrial fibrillation that conducts very rapidly over the accessory pathway to the ventricle. It causes ventricular fibrillation. And this is thought to be the mechanism of death in patients with pre-excitation. And there is an association with atrial fibrillation and patients with accessory pathways. We often see that. So that's why you don't want to give adenosine. You're potentiating conduction over the accessory pathway, and it might lead to ventricular fibrillation. And in any case, I would say that if you don't know what the diagnosis is, rather don't give adenosine in a broad complex tachycardia. If we have time, I'll show you some examples of SVTs where it can be a broad complex tachycardia and where you can use adenosine. But if you're unsure, excuse me, if you're unsure of the diagnosis, rather don't give adenosine and electric cardiovert the patient. Okay, does that answer the question?
Yes, there's a comment in the chat that it's a very difficult ECG. So I think
Yeah, I suppose.
because it looks more like a VTAC, and so I mean,
but that's also the point. If you see it and you're not sure, rather assume it's VT and treat it as a VT. Don't give it any.
Absolutely. I think those kind of basic guidelines make it easier to manage. And then there's another question just about the adenosine. Can it slow down the heart rate to a point of asystole? I'm not sure I understand the rest of it. It says, if possible, what could be the cause with normal doses? But I think you already mentioned that the adenosine inhibits the AV node. But the question is,
it does suppress the sinus node a little bit as well, and then it accelerates. So you might see, you're not going to get complete asystole. You might get a pause after you've given adenosine, but then the sinus rhythm starts again, and normally you get a period of where there's a relative sinus tachycardia after you've given adenosine. But it won't cause asystole.
Thanks so much for taking those questions, Adele. You can go on.
No problem. But at the same time,
sorry, I just want one comment. If you do want to use your cursor for specific things, I see if you go out of your share screen and you just go to your normal view mode, we can actually see your cursor. So if there's some specific things that you want to show, so like now, we can see your cursor. Yes, yeah. Good. So if there are specific things that you want to show, I know it's not ideal, but at least then you can show it.
Well, it might be better to do it like this then if you don't.
Yeah, it won't give our questions away, ne? I don't think so.
I don't know. Okay, let's do it like this, and then I'll. Oh, no. Now, for some reason, doing that I've got the screen sharing is paused. You can't, you didn't do that on your side. You can't do it on your
I
side, right?
hope I didn't do it on my side.
I tried to press on resume
I
share
don't,
and then it
but
doesn't work.
I can stop screen sharing you again.
Okay.
But I'm
Sorry about this.
sorry, man. So maybe we must just keep it simple without a
Yeah,
cursor.
I don't know why it does this. Okay, let me try again.
Yeah, but it's great getting all those questions. So please keep going, Adele, if you don't mind. So it's great to get the interaction.
It still says no, man.
Is it now not allowing you to screen at all or to share?
It still says your screen sharing is paused, and then there's a button I can click that says resume share, but when I do, it doesn't. Let me try and stop it. We can look at that, but the first problem now is to share it.
And we were doing so well until now.
I know. Maybe I should go out again and then come back in and then we carry on. Yeah. This is annoying. I'm sorry.
Okay.
No problem. In the meantime, I think, there were a few comments about Adele going a little quickly through the ECGs. I mean, I think we must just remember Adele is an electrophysiologist. So I think in her head, she kind of sees the rhythm and the conduction in the heart, and that's the way she understands it, because she sees this on a daily basis. So if you would like us to go through something again, please just put up your hand or make a comment, and Adele has been very kind. She'll go back to the ECGs and we'll go through it slowly. It's not a problem at all, as long as everybody understands what Adele is going through and the ECGs that she's showing us. So you're more than welcome to tell us to go back or stop or slow down, whenever you need to.
I don't understand this. It still says share screening paused.
Do you want to quickly send your presentation to me and then I can just share it, see if I can share it on my side?
I can try. Or can you but why is it doing this?
Yeah, it is a bit weird. It's doing that. And then it was working before.
Yeah, and I can see the resumes share and I click on it and nothing happens.
And if you close your presentation and just start from scratch.
Yeah, I've done that.
I think we can just blame Microsoft with all of the issues they were having yesterday and the day before. We can just blame them for it. Technology.
Janelle, can you comment on the question about the ice water in a plastic bag? In which specific conditions we will try that, or which tachycardias?
Yes. Oh, I see it now. So, in terms of the vasovagal maneuvers that you can do, the vagal maneuvers, in the old days, they used to say you could actually compress the eyes and increase the intraocular pressure. That is being taken off the guidelines completely. Adele mentioned the diving reflex, and you can try some ice on the forehead. But generally, that's what we would try, and then we would go on to adenosine. Especially if the patient is unstable, we don't waste too much time trying the vagal maneuvers. There was also a precordial thumb that used to be included in the previous APLS, ACLS guidelines, but that has also been removed. It does work, but obviously it's got other complications related to it as well, and medical legal issues. So yeah. Adele, I see you back on. We can see you clearly.
Yeah, I think it's working. And the precordial thumb is also more for ventricular torsades, not for SVT. But anyway, don't do that. Okay, let's try. I might just have to do it like this before we have an issue again. Okay, so that's the
Do you want to quickly go back to the ECG so that they can see that before I launch the poll? Can you go back?
No. Okay. Oh, no. It's giving me the same. Your screen sharing is paused.
Oh, no, man, every time you move it. Yeah. Okay, we're going to try and minimize any back and forth now, and I'll just share the polls while she tries to log on.
Can you see that?
Yes, we
Yes.
can see that.
Is it clear enough? I'm going to leave it in this view. So then I've got the arrow and hopefully everything works.
Can you zoom up a little bit on the ECG for us, Adele, or maybe close? Yes, that's much better. Thank you.
Okay, I'm going to share the question there. Can I launch?
Let me show the question. Yeah.
Sorry. Yeah.
Sorry, no, that was me going to the next slide. Okay. So what's the diagnosis? Is it the SVT, atrial flutter, atrial fibrillation, atrial tachycardia?
Okay, so we've only got about 30% people that voted. I think they might be struggling to see
Okay,
the
that's
ECG.
fine. Let's,
Is it possible to go back to the ECG, Adele? Maybe
stop
just
the
give us a little bit more time just to look at the ECG if possible.
we need to stop the poll.
Okay, I've ended it. And okay, there you go. Okay, so I'm going to share the results and then we can discuss it. So I think some people struggle to see it.
No, I'm sure. So it's again a fairly equal split. But 33% of you did say that you thought it was atrial flutter. Okay. So if we look at the ECG, it is a relatively fast, it's about 130 beats per minute, and it's a fixed rate. So if you've got sinus tachycardia, you might expect that there's a little bit of beat-to-beat variability. So it's relatively fast, fixed rate, regular, and a narrow QRS. And then if we I enlarge the lead V2 there for you. Then if you see, you can see that QRS, P wave, QRS, P wave, QRS. So we've got more A's than V's. The A's are regular and it's a 2-to-1 AV block. So then decided to give adenosine. And with adenosine, this is what was unmasked. So you can see that there's a sawtooth pattern here, clearly this, and in V1 as well. So the correct diagnosis is this is atrial flutter. Okay. So the next ECG, this is a 6-day-old infant with tachycardia and irritability. So I'm going to show you the questions and then we'll come back to the ECG before we launch the poll. So again, is this SVT, atrial flutter, atrial fibrillation, or a VT? Okay. Can you all see that?
Adele, is it possible to close the format bar on the right-hand side or just minimize it? That will make the ECG a little bit bigger for us.
No, how do I do that?
You might be able to... Okay, no, it's fine, no problem.
That better? I don't want to change too many things, just in case it stops working again.
No, that's perfect. We can see.
Okay, I've launched the poll. Let's see what people think. Great, we've got many more people answering, so that's great. Thank you for participating, and I'm going to close it now. So we're going to end the poll, and I'm going to share the results. Hope you can all see that.
Okay, so 68% of you think it's a SVT. That's great. So we've got a fast. Problem is things don't. So we've got a fast, regular, narrow, complex QRS tachycardia. Then we look for P waves. Can you see P waves? So initially, if you look, you might think that they aren't, but I've again enlarged one lead AVR here for you, and then we can see that there are P waves with what we call, this is a relatively, the next step, we look at the RP interval, so how long the measurement is between the R wave and the P wave, and this is a relatively longish RP interval. So, and there is one-to-one conduction. Again, we gave adenosine, and this is a slide I showed you earlier, where you can see that the tachycardia then terminated. Then there's one beat where there's a P wave QRS, and you can see it's pre-excited with a delta wave there. A couple of sinus beats where the pathway is blocked, and then the tachycardia initiates again. So you are right. This is indeed SVT. And more specifically, an orthodromic AVRT, where antegrade conduction is over the AV node and the retrograde conduction over the accessory pathway, orthodromic AVRT. Okay. So the next one, this is a 3-year-old again with a tachycardia. Questions: is it SVT, atrial flutter, atrial tachycardia, or VT?
Okay, great, Adele. I think we're getting the hang of it now. I think this is much.
Yeah, it's a pity that, anyway.
No, we can see really well, so don't worry. Okay, so about 62% is voted, so I'm going to end the poll and share the results.
Okay, so 90% of you said it's VT. I'm actually pleased by that. It means that you're listening. It's fast, it's regular, it's a broad complex. Then next to the side, is it a VT or a SVT? We need to try and see if there's AV dissociation. So again, this is more difficult than the previous one, but I've enlarged the one strip there for you. And then I can see that there are retrograde P waves. So there's no VA dissociation, but that doesn't mean it's not VT. It could still be VT with one-to-one retrograde conduction. So what did we say with this? We're not going to give adenosine because we don't know what the diagnosis is. So we first stabilize the baby, do a cardioversion, and then we decide what the diagnosis is. So after cardioversion, you can see that there's a short PR interval. There's a delta wave that you can see more clearly here in the precordial leads. It's a broad QRS, and there are repolarization abnormalities. So this is in fact pre-excitation or WPW syndrome. So that was a SVT. So if this patient now comes back with that rhythm, then you can give adenosine because you know that the diagnosis is SVT. This is an antidromic AVRT where the conduction is the opposite to what I've showed you before, where conduction antigrade is over the accessory pathway and retrograde over the AV node. It's an antidromic AVRT. But to say it's VT if you're not sure is perfect. Okay, this is a 12-year-old who presented with syncope during exercise, then came into casualty with palpitations, and this is the ECG. So the questions are, is this SVT, AVRT, atrial fibrillation, atrial tachycardia, or a VT?
It's a difficult one. People are slow on this one. So we've got about 48% people that's voted.
Okay.
Okay, I'm gonna
Let's
write
see what
in
they
poll
say.
there and we'll share the results.
So again, if you're not sure, 44% of you said the VT. That's not unreasonable. 16 SVT, 25% thought it was atrial fibrillation, and 15% thought it was atrial tachycardia. So this is fast, irregular, broad QRS, right? So in EP we call that the FBI, fast, broad, irregular tachycardia. Now, does this remind you of something that we looked at earlier? It is, in fact, atrial fibrillation, but it's pre-excited atrial fibrillation. So it's similar to that slide where I showed you that we would not give adenosine because this is an emergency. So what would you do next in this patient? Would you give adenosine? I hope no one says that. Would you cardiovert? Would you give propranolol? Or would you arrange for follow-up with a pediatric cardiologist the next day? Okay, let's see.
Yeah, well done. I'm going to end the poll.
Fantastic. 83% said cardiovert. No one gave adenosine. That's fantastic. 13% wanted to give propranolol, and 4% said sent home to come back to the cardiologist the next day. So, in fact, this is an emergency. You don't let the patient leave the ER in that state. You immediately electrically cardiovert. Then it's not unreasonable to start propranolol and refer to a pediatric cardiologist or even an electrophysiologist, because this is an electrophysiological emergency. This patient should, in the ideal world, in the ideal setup, get a EP study and an ablation as soon as possible. Because, like I said, we think that this is the mechanism of sudden cardiac death in WPW. Okay.
Adele, there's a question on the group from Sinazo Kumalo. For VT and AF, do we do cardioversion or defibrillation is the question.
So for atrial fibrillation or SVTs, any SVT, you do cardioversion, so synchronized cardioversion. For VT, it would actually, VT is still cardioversion, synchronized cardioversion. Ventricular fibrillation is defibrillation, where it's not, your defib is not synchronized. Does that make sense? Because if you do, the difference is if you synchronize, if you look at your defib, you can choose sync on or off. If sync is on, then it means the defib tries to synchronize when it delivers the shock. And the reason we do that is so that you don't deliver the shock on a T wave, which can then induce ventricular fibrillation. If it's asynchronous, if you don't have sync on, then it will just shock. And that you do when you've got ventricular fibrillation, because the QRS complexes are small, it's irregular, the morphologies change from beat to beat, so the defibrillator can't sync with the QRS. So then you just you defibrillate with sync off. Does
Thank
that
you.
help? Okay.
I think that's a very clear explanation. Thank you.
Right. So this is the 7th. I've got I know I'm over time with our technical issues. I think I've got 3 more ECGs. So if you want me to stop, I can. Otherwise, we can.
No, I think we're good for time. You can go.
Okay. So this is an 8-year-old who also presented with palpitations, and this was the ECG that was obtained in the emergency room. What is the diagnosis? Is this a SVT, atrial fibrillation, atrial tachycardia, or a VT?
Gosh, I'm going to share now. Sorry, I'm a little bit delayed. So let me just stop sharing this one. Sorry about that. Great. Another difficult one.
This is a difficult one.
Okay, I'm going to end the poll and we'll share the results.
Okay, so again, split fairly in the middle, although almost 40% of you thought that this is a AV-NRT. Did we share the right? Did we share this poll?
Oh, sorry, did I share the wrong? Was it poll number? What's on your right?
This is 9, but
Yes.
I might have it wrong on the form I sent you.
Okay,
Anyway, so let's look at it. So this is fast, regular. Now, would you think this is a broad or a narrow complex? This is slightly broad, I would think it, but not as broad as the ones we've seen before. And then we look at P waves. Again, if you follow, it's very difficult on this ECG to see if there's VA dissociation. I myself struggled with this. But we see that it's got a right bundle branch block type morphology, the QRS complexes, and it has a northwest axis, so where it's negative in V1 and negative in AVF. So if we remember that diagram, the axis would be here, northwest axis. And this is where it's an example of why it's important to look at every beat on the ECG. So even though it looks regular and monomorphic, so every complex is the same, there was this one beat here that looks slightly different to the rest and slightly broader. Do you agree? So this, with the right bundle branch morphology and the northwest axis, is most likely VT, and a specific type of VT. It's fascicular VT, Balhausen's VT, or verapamil sensitive VT, it's also called. But again, I would treat this as VT, and then try and figure out the diagnosis afterwards. This is very amenable to ablation, which is what we did here. Mapped out the green dots are the conductions of the fascicles. So this was a posterior fascicular VT. The anterior fascicles are there in orange, the His is yellow, and the red dots are the ablation spots. So this was in fact, a fascicular VT. And it's a very specific, typical ECG of a relatively broader than you expect in a normal SVT in a child, with a northwest axis and a right bundle branch morphology. Okay, next one. This is a 10-year-old who also presented with palpitations, and this is the ECG. Question, is this a SVT, AVRT? Is this atrial fibrillation, atrial tachycardia, or is this AVNRT? And here's the ECG again.
Sorry, I think I have the wrong choices here. I think it's actually the previous one.
Yeah, that was probably my fault.
Yeah, no worries.
But I think we can stop that then, because I'll show them the answer. Okay, so most people still thought it was a SVT, which is great. It is. It's a tachycardia. It's regular, it's narrow complex. And do you think you can see P waves? I would be completely happy with it if you thought you said you can't see P waves. But if you look in V1 specifically, that's typical of what we call a pseudo R wave in V1. And it's basically fused with the QRS complex, and that is a retrograde P wave. So this is a typical ECG for typical AVNRT. So what is AVNRT? AVNRT, you've got two pathways within the AV node. There's a slow pathway and a fast pathway. So what happens is that the electricity conducts normally over the fast pathway. Then you might get a premature beat when the fast pathway is still refractory, so the electricity conduction can't go over the fast pathway, so it goes down the slow pathway, and then you'll see a beat with a longer PR interval. And because the tissue of the fast pathway has now repolarized and it's ready to receive a signal again, conduction goes down the slow pathway, finds the fast pathway, goes back up the fast pathway, and then the tachycardia runs in a circle within the AV node. So that's AVNRT. Okay.
Adele,
Yeah.
can I just direct you to another question that's come through online from Anonymous? For the VT,
Yeah.
I think that was the verapamil sensitive one that you had shown. What was the beat that looked different to the others? You had shown us one QRS complex. That I think the question was just sort of what is the origin, or what was the beat?
It?
Yes.
It's likely you can get capture beats or fusion beats during a VT. Where capture beats is when the sinus, because you've still got sinus rhythm in the back, or P waves, and that can conduct antigrade. So capture beat is when that P wave then captures the rhythm, and then you get a QRS that actually looks normal. This is wrong. It's not a capture beat. This is rather a fusion beat, where you get fusion between conduction over the AV node and the VT. So if you see capture beats or fusion beats, that makes you almost confirms the diagnosis of a VT. On this one, I think looking at it now, it's rather fusion between the VT and the sinus than a capture beat.
I think this is just evidence why we need an electrophysiologist. Thanks. Thanks so much for that, Adele.
Okay. So this is a 12-week-old with a tachycardia, poor feeding, tachypnea, failure to thrive. That's the ECG. This is the questions. Is it SVT, atrial fibrillation, atrial tachycardia, or atrial flutter?
I hope I now have the right one. So let's just see. Yes, it is, ne?
Yeah.
Yeah, great. So fire away, guys. Adele, you're hardcore with these questions.
It's the same question again and again.
Okay, I'm going to end the poll. People are slowing down a
Okay.
little bit. Okay, and share the result.
People are probably starting to lose the will to live by now. Okay, so something, it's SVT, and then it's fairly equally split between SVT, atrial fibrillation, and atrial tachycardia. Okay. So I did help you a little bit on this ECG. I don't know if you saw. So it's fast, it's irregular, but a narrow QRS. So most likely this is not a VT. And then we look at the P waves and the QRS complexes. And the arrows here, you can see I pointed to P waves. So there are P waves, and there seems to be a 1-to-1 relationship. And if you look at the P waves, you can see that they have all slightly different morphologies. That one's more rounded, this is more peaked, that's negative in lead 2. So this is in fact the atrial tachycardia, and it's a multifocal atrial tachycardia, to be specific. It can be difficult to treat, and it may be incessant. It is rare, but I thought it was a nice ECG to show. Okay, we've got one more ECG. I think, yeah. So this is a 7-week-old that was referred because someone heard an incidental murmur, and as part of the workup, the ECG was done. When I look at the ECG, then the questions are, is this sinus bradycardia? Is it Mobert's 2 heart block? Is it complete heart block? Or is it long QT syndrome with functional 2-to-1 AV block? I hope we've got the right poll. There's the ECG again.
Do we have it right there?
Yeah.
Yeah, okay. Okay, I'm going to end it and just share the results.
Okay, so well done. I'm very impressed. 41% of you said long QT syndrome with functional 2-to-1 block. That's the right answer. So if we look at the rhythm, it's slow, it's regular. We have the orange arrows, P waves here, and QRS complexes with the blue arrows. So there are more A's than V's, so there is a form of heart block. We look at the relationship, so it's not sinus bradycardia, right? Mobert's 2 heart block would mean you actually can't say whether it's Mobert's 1 or Mobert's 2 heart block when you've got the ECG with 2-to-1 block, because remember, with Mobert's, you need to know whether there's a fixed relationship between the P waves and the QRS. Is the PR interval fixed, or does it decrement or prolong? In Mobert's 1, it prolongs and then you have a drop beat. In Mobert's 2, the PR interval is fixed and then you have a drop beat. So if you have 2-to-1 block, AV block, you actually can't comment on whether it is Mobert's 1 or 2. But here we can see that the P waves, it's regular, definitely 2-to-1. And if you measure the QTC, like I showed you to do, or told you to do in V5 or lead 2, we can see that the QT is prolonged at 490 milliseconds. And that is a P wave at the end of the T wave. So the ventricle hasn't repolarized yet, so can't receive the next signal. So that's why it's functional heart block, because there's nothing wrong. We call it functional block. There's nothing wrong with the AV nodal conduction. The ventricle hasn't had time to repolarize to receive that impulse. And that's why there's no QRS that follows that. So that this is, in fact, long QT syndrome with functional 2-to-1 block. Are there any questions on this one? We're happy? So in summary, I want to say, don't panic when you see a ECG. Use a systematic approach. Remember that there are important patterns that you need to recognize, but at the same time, avoid making a snapshot diagnosis. Look at everything, go through everything, look at every beat on the ECG. And remember that we've got age-related values and changes. And then I would encourage you just to go look at the webinars on the CASA website. There are sets of 3 webinars, each about an hour and a half long per session. So that's a lot of ECGs to look at if you are interested. It's available to view on the website. And if you would
Adele?
like, yeah.
There's sorry to interrupt. There's one question from Andrew Ferrerina. I think just about the last ECG. It states the tangent, there's a whole lot of questions coming in now. It states that the tangent on the slope of the T wave here takes the adjacent P wave into account. Would this not overestimate the QTC? Maybe you can just explain that for us.
Yeah, it's a difficult one to do it in. Perhaps I should have showed you that one rather. But the P wave is in the T wave. So the QT is prolonged. Even if you were to draw it more acutely, the QT would still be prolonged here. Let's go back to the first ECG.
So I think the next question has to do with
It
the
might
same.
be if you use lead 2, it might be easier for you to see, because if you use the tangent here, you can more clearly see where the P wave is, and that would still be prolonged, because it's still 5, 10, 15 small blocks. 5, 10, 15. Yeah, it's about the same as I measured there in V5. So if you use that beat in V2 or here, and you drew the tangent here, you would still have 5, 10, 15 small blocks for the QT. So that would still, the measurement would still work out the same. But you're right, it can be difficult. Okay.
There's one question about comparing to ECGs, but I think, you know, when we share your presentation with everybody, they can have a detailed look, because it's a bit difficult to see ECGs on the screen. There is a question that asks, once the diagnosis of prolonged QT has been made, what is the next step in the management of this patient?
So beta blockers. Beta blockers are the first line treatment. And it's important to also then screen first degree family relatives, do ECGs in all of them. If it is a family who will be able to afford it, I recommend genetic testing, because it does influence further management and also the prognosis to a degree. But first degree management is beta blockers, and importantly, there's a website called crediblemeds.org that I always give the patients a link to. It's got a list of all the drugs that should be avoided in long QT syndrome. So the most important thing, beta blockers, being compliant with a beta blocker and avoid taking any medication that might further prolong the QT interval.
Thanks, Adele. I think you've really got everyone full of questions. I'm going to take one last one, because we have to round up now. It's from Sinazo Kumalo. What is the significance of ST segment changes, and what are the best leads to look at them?
Yeah, that's going to be maybe a bit too long to discuss here, because it depends what causes it. If you've got diffuse ST segment changes, then you will see changes in all the leads, like you can see with a pericarditis or electrolyte disturbances, or early repolarization. But if you've got ischemic changes, then it will depend on where the ischemia is, where the lateral leads will be lead 1, AVL, V5 to V6, V1 to V3, anterior, V3, V4, septal, and the inferior leads being 2, 3, AVF. So depending on where the ischemia is, it will affect the changes. And with bundle branch block, left bundle branch block, it will be diffused. You can't say anything about ST segment changes then. And the same with if you've got ventricular pre-excitation, you will have the most ST segment changes in the leads with the most pre-excitation. So that's, I'm not sure if that's going to answer the question. But it depends on what the cause for the ST segment changes are.
Adele, I think you've really got everyone busy and typing and asking lots of questions, and we've gone a little bit over our time. We had 1 or 2 technical issues, but if you don't mind, I think we're going to end it here. We will definitely distribute your ECGs and your lecture to everyone who's attended today. And they're welcome to engage with any of the cardiologists, to engage with you on an email basis if they have any other burning questions.
And I think go watch these ECG webinars. A lot of your questions will be answered there. Like I say, each of these sessions, I've got 3 sessions of an hour and a half or hour and 40 minutes. So that's a lot of teaching there, and it is available on the website.
No, excellent. Definitely. I think all these resources make a huge difference, because often you don't know where to look for the information that you need. And I think these links are going to make a huge difference. That first session was absolutely amazing, Adele. Thank you so much for that. The responses, the questions have just been indicative themselves of how, easy ECGs can be, up to how difficult and complex ECGs can actually get. And just a reminder to all the registrars that an ECG is actually a bedside investigation. Often when you go into the pediatric units and you ask for an ECG, they've got to run to the other end of the hospital to the cardiac unit to get it. But you just demonstrated how much information you can actually get from ECGs. And I think this session was helpful not only for the general pediatricians, but for all the specialists, subspecialists as well. So thank you so much, Adele. That was an excellent presentation.
Okay, sorry, it's my pleasure, and apologies for the technical issues. Thanks.
In the interest of time, we're not going to take any extra questions, because we've taken a lot of questions as we've gone along. What we're going to do is we're going to go right on to our next speaker, because we're going to change gears a little bit from ECGs. We're going to start looking more generally at pediatric cardiac emergencies. Dr. Libia, who's the public relations officer and our social media correspondent from the Paediatric Cardiac Society, is going to be taking us through her lecture on diagnosing and management pediatric cardiac emergencies. She's a pediatric cardiologist in private practice at Sunninghill Hospital, Netcare Sunninghill Hospital, which is one of the biggest congenital cardiac units on the continent. Dr. Libia, I'm going to hand over to you. And Mamayela, you are welcome to share your screen and go ahead. You can put your video on as well, please. Dr. Mamayela, are you able to share your screen? Perhaps just unmute yourself. Marty, I'm just going to see if I can get hold of Dr. Libia.
Okay, that's perfect. I can see her online, but yeah, maybe just see if she's struggling to unmute or share. In the meantime, should we just like all stretch our legs a little bit? I thought that ECG session was hard on my brain. So a lot of focus, thanks to Adele, going into that session. So we can maybe just take a little bit of a breather and just like 1 minute for us to get Mamela set up. So just like take a little breather, make sure your travel mug full of coffee is still filled up. And this next session is also going to be full of quizzes, so you need to get your brain all fired up and ready to learn. So I'm just going to see if there's any extra things in the chats. Any extra questions? Maybe I can just ask some of our cardiologists that is part of our panel. As part of APLS, we always teach that you do a synchronized shock as long as there is a pulse. And maybe I can just check that with Adele as well. Is that also the approach that we should be taking? So we always teach if there's a pulse, you do synchronized shock. And if there is no pulse, then you just obviously do asynchronized. Is that the approach, Adele?
Yeah, sorry, it will be because for all your monomorphic tachycardias, including VT, you won't be pulseless. You're right. So VF, pulseless, asynchronized shock.
Okay, great. Yes, I don't know if there's any other burning questions that people want to put in the chats. Janelle, that you find, Mamela?
Yes, shame. We're having a few little technical issues on that side. I'm going to ask our next speaker. Wait, there we go. Mamayela, we can see you. Can you hear us at all, Mamayela?
Yes, I'm here.
Ah, excellent. We can see you and we can hear you.
Yes, I just need to share my presentation. I'm sorry about that. Okay. Can you see my presentation?
Yes, we can see. Excellent. Everything is visible. Thank you. All yours.
Thank you very much, Prof, for that introduction. As Prof mentioned, I'm going to be talking about pediatric cardiac emergencies. There is no relevant disclosure for this presentation. Pediatric cardiac emergencies are not rare. They can be the first presentation of a congenital heart disease or acquired heart disease. As you know, congenital heart defects are the commonest birth defects that are known to men. They affect about 1 in 100 babies. And 25% of these babies will have what is called a critical congenital heart defect. And they are most likely to present as an emergency during the neonatal period. Pediatric cardiac emergencies can also be a complication of an already diagnosed cardiac lesion. As you know, in our country, we have problems with the waiting period for our patients to get surgery. So someone who's diagnosed with tetralogy of Fallot, who's still waiting for surgery, may present in your emergency unit with a cyanotic spell. On the good side, the overall outcome of patients with congenital heart defects has improved significantly over the years. So more and more of our patients are surviving into adulthood. So it is also not unusual that you might come across someone who has an operated congenital heart defect presenting with a complication. In critical lesion, the ultimate prognosis depends on a timely and accurate assessment of the structural anomaly, early management, stabilization, and safe transportation. In this presentation, I would like to look at the following emergencies: cyanosis in a newborn, hypercyanotic spells, shock, congestive heart failure, and pericardial effusion. I'm not going to look at cardiorespiratory arrest, arrhythmia, as Adele has already gone into that in detail. Cardiac emergency post-operatively or in patients with single ventricle physiology, cerebral vascular accidents, and cerebral abscesses, which can be a complication of cyanotic congenital heart disease. Our first scenario, you are called to labor ward because a male neonate that was delivered by cesarean section at 39 weeks of gestation appeared blue immediately after birth. The sisters have tried to resuscitate the patient with suctioning, stimulation, and initiation of oxygen therapy, but the color just did not improve. What is the problem with this patient? So this is a child with a cyanosis. Obviously, cyanosis is not a diagnosis, it's rather a sign, and it is described as bluish discoloration of the skin and the mucous membrane. This is as a result of increased reduced hemoglobin or deoxygenated hemoglobin to about 3 to 5 grams per 100 ml in the cutaneous vein. There are different types of cyanosis. Central cyanosis, which is the one that is important for us cardiologists, is associated with desaturation of arterial blood. Then peripheral cyanosis, this is associated with normal arterial oxygen saturation. But what's happening is that there is increased peripheral tissue extraction of the oxygen. This we often see in patients if they are exposed to cold or in emergency situation in patients with hypovolemic shock. It's also important to understand the concept of differential cyanosis and reverse cyanosis. So if the saturation is different between the right arm and the leg, by more than 4%, there is either differential cyanosis or reverse cyanosis. If the cells are low in the leg but higher in the right arm, that is what we call differential cyanosis. And we see this in congenital heart defects that are duct dependent for systemic blood flow. So as you know, the pulmonary artery is carrying deoxygenated blood. The aorta is carrying oxygen-rich blood. If there's a connection between the aorta and the pulmonary artery through a PDA in a patient where there's obstruction in that aorta, then the flow of blood down that PDA into the aorta, therefore the lower part of the body will be blue, will be cyanosed. In the case of reverse cyanosis, it's not that common. We see it in some complex congenital heart defects, like transposition of great vessels with coarctation of the aorta. In this situation, you see the cells are higher in the right arm, but lower in the leg. I think another important cause of differential cyanosis that you will come across if you are dealing with newborn is persistent pulmonary hypertension of the newborn, which needs to be distinguished from cyanotic congenital heart disease. This is a child with cyanosis. The one on the left has got peripheral cyanosis. You can see the hands are cyanosed, but the tongue and the lips are quite pink. This is very common in the newborn and even infants. It's called acrocyanosis. This is caused by immature vascular tone that leads to delay in drainage of blood in the hands and therefore more extraction of oxygen. It's not significant. We're not worried about that. And then the other child has got central cyanosis, which is really a medical emergency. It is difficult to detect cyanosis in children that are dark. The first place that we need to look for cyanosis is the tongue. The reason being the blood flow in the tongue is quite excellent, and also the fact that the color of the tongue is the same in everyone, is not affected by race, is not affected by ethnic background. So also if you are not sure, but actually, in fact, every patient that you see, you need to do a pulse oximeter. I think we must consider a pulse oximeter as one of our vital signs. So in terms of your differential diagnosis, when you faced with a child, a newborn with cyanosis, for me, I like to put things in boxes, and when I have a child with cyanosis, I have to think which organs or which systems are important for you to be pinged, to deliver oxygen-rich blood to the body. The respiratory system is important. The airway need to be patent. So if there's obstruction to the airways, and then the oxygen cannot get to the alveolar. If there's problems with alveolar capillary diffusion, maybe due to pneumonia, you will not be able to get the oxygen into the blood. The central nervous system is very important because it controls your breathing. There needs to be a good functioning heart, which is able to pump this oxygenated rich blood to the body. The common causes of cyanosis in the newborn is really respiratory. And mostly we see meconium aspiration syndrome. In premature babies, we see hyaline membrane disease. We then also see babies with TTN that respond nicely to oxygen, and the problem usually resolve quite quickly. But importantly, we need to exclude cyanotic congenital heart defects. In terms of remembering the congenital heart defect that causes cyanosis, there is that the 5 T's of tetralogy of Fallot, transposition of great vessels, tricuspid atresia, total anomalous pulmonary venous condition, and truncus arteriosus. There are also other defects, but the most common cyanotic congenital heart defect that we see is tetralogy of Fallot. But in the newborn period, the most common lesion that we see is transposition of great arteries. When we approach congenital heart defects, we always think about those that are associated with increased pulmonary blood flow or normal pulmonary blood flow, and those with decreased pulmonary blood flow. In terms of those that causes increased pulmonary blood flow, the child will not only be cyanosed, but will also have features of congestive heart failure. Then in terms of those that causes decreased pulmonary blood flow, again, it's just the obstructive lesion. If the tricuspid valve is not opening, you have tricuspid atresia. If your pulmonary valve is not opening, maybe you have pulmonary atresia or critical pulmonary stenosis. There's also total anomalous pulmonary venous drainage. We have both increased or decreased pulmonary blood flow depending whether there is obstruction to the veins or not. In terms of your approach, really you can already suspect a cyanotic congenital heart defect on the basis of history, physical examination, and some basic investigations such as chest X-ray, ECG, and arterial blood gas. Internationally, they are fortunate that most of their patients have got access to antenatal sonars. So many of these newborn babies will be born already with a diagnosis. In our settings, I find that most of our patients do not have access to antenatal sonars, or even those that have access, we find that it's not very easy to diagnose congenital heart defect if you are not experienced or trained in fetal cardiology or fetal sonar. So in terms of other investigations that we do, echocardiography is the mainstay of our investigation that will confirm diagnosis in most cases. If we are still unsure about certain things, we'll go on to cardiac catheterization, which nowadays we do mostly for intervention rather than diagnosis. Other investigations are CT, angiography, and MRI. In terms of your history, there are certain things in the history that can already help you to establish what could be the cause. I think what is important is to differentiate, is this respiratory, which is another common cause which is the commonest cause of cyanosis, or is it cyanotic congenital heart defect? So in terms of the history, a history of diabetes mellitus or gestational diabetes, these children are at risk of congenital heart defect, but they are also at risk of complications, other complications. They can have meconium aspiration syndrome. They can also have hyaline membrane disease. Alcohol intake is a risk factor for congenital heart defects. Medications such as lithium and anti-epileptic medications such as sodium valproate increase your risk of having congenital heart defect. If you have a mom who has been diagnosed with chorioamnionitis, that increases your risk of having congenital pneumonia as a child. A history of fever and rash may suggest that this mom during the pregnancy may suggest that she has had rubella, which is also one of the risk factors for congenital heart disease. Age, the older you are, the higher the risk of having certain genetic syndromes such as trisomy 21 that are associated with congenital heart defect. Other histories like pre-labor rupture of membrane, also that may suggest that this child is having congenital pneumonia, meconium stained liver, premature or post-stage kids are usually at risk of meconium stained liver and meconium aspiration syndrome. Being born by cesarean section increase your risk of having transient tachypnea of the newborn. A family history of congenital heart defect, as we know, the risk is of having a child with congenital heart defect is 1 in 100. But the moment you have a child with congenital heart defect, your risk increases to 10%. On examination, doing the vitals alone, you can start to see that this child is probably having a congenital heart defect. So doing a blood pressure is not only important to do one blood pressure, but do 4-limb blood pressure to see if there's a gradient between the blood pressure in the right arm as well as the leg. Because if there's a gradient of more than 10 millimeters of mercury with the blood pressure lower in the lower limbs, that may suggest that this child is having coarctation of the aorta. The pulse, I think what is important when we are having a cyanotic child, the pulse is not only the rate, but whether they are present in the brachial and the brachial as well as the femoral, or they are weak in the femoral. Doing the pulse oximeter as already mentioned, because it can be difficult in that patient to pick up cyanosis. Dysmorphism, trisomy 21, at risk of increased congenital heart defect. When a patient has got severe respiratory distress, it's most likely to have a respiratory cause of the cyanosis. What I have found in our patients is that they tend to have what we call quiet tachypnea. So the child will be cyanosed with a rapid respiratory rate, but however doesn't have much signs of respiratory distress such as recession. Abnormal breath sounds such as crackles or decreased breath sounds will suggest a respiratory cause. Listening to the heart sound. The second heart sound, if it's abnormal, it could be single or splitting, which I should be honest, it's very difficult to comment on this in a newborn with tachycardia. But if you can pick up that, it can suggest that this child has got a serious heart problem. Cardiac murmurs may be there. A child with a serious heart problem may not have a cardiac murmur. So the absence of a cardiac murmur does not mean the child doesn't have a congenital heart defect. An important test that needs to be done to distinguish respiratory as well as cardiac cause of cyanosis is called the hyperoxia test. In this test, we administer 100% oxygen for about 10 to 15 minutes. After that, we do arterial blood gas, preductally and postductally. So preductally is in the right arm, and postductally is the child has got a UAL line, you do it through the umbilical arterial line. So if the partial pressure of oxygen does not increase or is less than 150, this suggests a critical cyanotic congenital heart defect. If it increases to more than 250 millimeters of mercury, this is more suggestive of a respiratory cause of the cyanosis. There are some congenital heart defects associated with increased pulmonary blood flow, such as truncus arteriosus, such as total anomalous pulmonary venous drainage that may have an increase in the PaO2, but often it lies between 150 and 250 millimeters of mercury. So if a child fails the hyperoxia test, and that is the partial pressure of oxygen is less than 150, this child needs to be started on prostaglandin and referred to a cardiologist. The chest X-ray, which is easily accessible, is one of the first tests that most people will do. This one is very important because it can already tell you the obvious causes of the cyanosis. For example, in this X-ray here, we've got congenital diaphragmatic hernia. You can also pick up pneumothorax or pleural effusion that also need to be corrected immediately. You also look at the cardiac configuration. There are certain shapes of the heart that will suggest a specific congenital defect, like egg on a string, boot-shaped heart, snowman appearance. But I should say, I see a lot of neonates with cyanotic heart disease, but this classic cardiac silhouette that I've already mentioned, they are rarely seen in the newborn period, especially the total anomalous pulmonary venous drainage with snowman appearance. We hardly see that in the newborn period. Another important thing is commenting about the aortic arch, the size of the aortic arch. Some of the complex heart disease can be associated with right-sided aortic arch. As you know, a normal arch is left-sided. Other things you must look at is the organs, is the solitary, is the liver on the left side and the stomach, the liver on the right side and the stomach on the left. If you're starting to see like dextrocardia with situs inversus where the organs are swapped, it's very likely that you are going to have a congenital heart defect. You also look at increased or decreased vascular marking, with decreased vascular marking suggesting that there might be a cyanotic heart defect with a decreased pulmonary blood flow, such as tetralogy fallow, tricuspid atresia, as well as critical pulmonary stenosis. Laboratory workup is always important because you need to exclude sepsis, neonatal sepsis, and I think all patients should be covered for neonatal sepsis until we can confirm that this is a cardiac cause of cyanosis. The ECG is usually non-specific. It's non-specific, but the moment you see this ECG, which is showing a left axis deviation because you've got a positive QRS in lead 1 and negative in AVF, there's a left axis deviation. And the thing that is remarkable is the absence of right ventricular force. So this is a classic ECG that we see in patients with tricuspid atresia. So these are not specific to if you see biventricular hypertrophy or right ventricular, it is not telling you what congenital heart defect might be there. But this one is very classic of patients with tricuspid atresia. In terms of starting the management, you always go through the ABC, you give your patient oxygen. If not improving, you might have to intubate and ventilate. You must start prostaglandin E1. You must correct the correctable. Make sure that you maintain a neutral thermal environment. You correct the hypoglycemia, electrolyte abnormalities. Start antibiotic therapy until your blood culture results. Some patients who are in congestive heart failure will need antifailure therapy. If the blood pressures are not improving, you might have to start inotropic support. You continue to monitor this patient and you refer to a cardiologist. With regard to prostaglandin E1, this is very important drug process. Unfortunately, it is very expensive. So in some centers, you might not have the IV prostaglandin E1, you might have prostaglandin E2 that you have to give orally. This drug is very important to increase pulmonary blood flow in patients with congenital heart defects that are drug dependent for pulmonary blood flow. It is also important for those that are drug dependent for systemic blood flow. This drug is used to reopen the patient ductus arteriosa. We usually start at a dose of 0.05 microgram per kg per minute. You can increase it until your patient has improved. You can as high as 0.4 microgram per kg per minute, but the higher the dose you use, the more likely you will have side effects. The side effects of prostaglandin include apnea, bradycardia, hypotension. So when you are giving this patient prostaglandin, you must be sure that you can resuscitate the patient. So you need to have your resuscitation trolley ready. You need to be on continuous monitoring. I always advise that you have to have two lines. One for giving, because if your patient needs to be resuscitated, you don't want to be stopping the ibuprofen while you give other medication. So have two lines, even if one of them must be essential lines. Patients with critical congenital heart disease may worsen on prostaglandin. And these are patients where they have lesions where there is there is increased left atrial pressure. For example, patients with hypoplastic left heart syndrome with a restrictive PFO. Some Epstein anomaly can also worsen. A patient with total anomalous pulmonary venous drainage with obstruction can also worsen when started on prostaglandin. Important to mention, when you are transferring patients on prostaglandin E1, IV prostaglandin, I always recommend that the patient be intubated, because you don't want your patient to be intubated and ventilated, because you don't want your patient arresting in the ambulance or having an apnea in the ambulance, and the emergency people have to start resuscitating on roads. So it's safer to intubate. So important, have two IV access, continuous monitoring, be ready to resuscitate and transfer with a patient who's intubated and ventilated. Echocardiography is the test that we will come and do as cardiologists, and now you are also going to start learning to do echoes. So you need to be, this is just a picture to show, like, this is the, there's a long parasternal, there's a parasternal long axis that is showing the right ventricle, the left ventricle, as well as the left atrium and aorta. On this image, there is what you call 50% aortic override. It's usually associated with either tetralogy of Fallot, pulmonary atresia with a VSD, double outlet right ventricle. I think Sam will go into more details about this kind of sonar that you might come across when you start echoing. And then on the other side, you've got a apical four-chamber view that is showing that the right ventricle is very small compared to the left ventricle, and they look to be where the tricuspid valve is supposed to be. There's a muscular tissue there that is echo-bright. That valve is not opening. That child is having tricuspid atresia. So echo is easily accessible, is not that cheap, but it is available in most centers. Doesn't have much complication, so it's something that we need to start doing so that we can diagnose and refer patients who have congenital heart defects accordingly. Other imaging modalities that we do CT angiogram. As you can see, the other picture there is showing there is a single shunt that is coming out of the heart, giving rise to the pulmonary artery as well as the coronary artery that you cannot appreciate on this image. This is a patient that has truncal arteriosus. And the other CT angiogram there is showing that the aorta is coming from the right ventricle, the pulmonary artery is coming from the left ventricle. This is a patient that is having transposition of great vessels. So mostly we'll get the diagnosis on echocardiography. Sometimes we do have to go to CT angiogram. Most of us don't have access to MRI. And sometimes we do go to the cath lab, especially in some patients like with pulmonary atresia, where we are suspecting that the source of pulmonary blood flow is marked. In terms of
Dr. Libya,
yes,
may I interrupt you? Just there's a few questions, if you don't mind, while we are covering the topic. There's a question from Helen Okafo, who's asking, please, how do we give 100% oxygen for 10 minutes if a child is not intubated?
you can use headbox oxygen if you have. You can also, if you give face mask oxygen, you are also giving a very high, you may not be sure of how much oxygen you are giving, but it should be more than 85% oxygen. So I would suggest headbox oxygen as well as a face mask.
Okay, perfect. And then Nilandra Chetty is asking, is there any place for using oral prostaglandin given hourly via the nasogastric tube?
Yes, I think I touched briefly on that. Most of our primary and secondary hospitals don't have access to prostaglandin E1. I think one ampule is about 3,000. I should say even some of the private hospitals in Johannesburg don't have prostate. So you can use oral. It is as effective as the IV form. It's just that it's a lot of work. There's a lot of work. You will have to get someone dedicated to go and give the child hourly and to make sure that you don't miss a dose.
Excellent. And then there's two more anonymous questions. The first one says, when providing oxygen to infants needing Proston, do you need to provide a lower FiO2 to prevent dropping the pulmonary pressures?
That is a good question. So as we know, oxygen is a potent vasodilator. Being a potent vasodilator, it means if you give high fraction of oxygen, you're going to dilate the pulmonary vessels, and that will lead to increase in left to right shunting if you have a large defect such as ventricular septal defect. So in patients with congenital heart defects that have increased pulmonary blood flow, if you give that high oxygen, you might worsen their cardiac failure. So I suggest that in the setting where you have a cyano child with less of 50%, you give as much oxygen as possible and get the diagnosis as soon as possible. But once we have made the diagnosis and we know what the lesion is, then we will start weaning the oxygen. I don't know what other panelists feel about that.
Also, in keeping with the oxygen levels, the next question and the last question states, what are the acceptable saturation levels for a cyanotic baby on oxygen? And in brackets, they do state providing that the child is not acidotic.
Yes, so we usually accept saturation above 75%, and it's true that we go clinically. The child needs to be comfortable. So yes, we accept we say more than 75% is acceptable.
Thank you so much.
Oh, thank you, Prof, for those questions. So when the patient gets to our center, once we have made the diagnosis of a congenital heart defect, we as cardiologists can start with some palliative procedures. For example, we can do balloon atrial septostomy, balloon valvoplasty for patients in with critical valvular stenosis, such as critical pulmonary stenosis. We can do PDA stenting and RVOT stenting if we cannot get the patient to have surgery as soon as possible. And then some patients are immediately sent to surgery where they can have palliative surgery in the form of modified Lalok-Tau section for central shunt, or they may just have definitive surgery. But mostly in the neonatal period, we tend to do palliative, like modified Lalok-Tau section. So this is a video that is showing balloon atrial septostomy. So balloon atrial septostomy is a procedure that we do to enlarge the interatrial communication, the PFO or the ASD. We usually do this in patients with transposition of great vessels, but there are other lesions as well with a restrictive PFO where we need to improve intercardiac mixing. For example, a patient with pulmonary atresia, intact ventricular septum, patients with hypoplastic left heart syndrome with a restrictive PFO. So we can do this procedure. What we do, under ultrasound guidance or under fluoroscopy guidance, we advance a balloon tip catheter into the right atrium. We cross the interatrial communication, go into the left atrium, inflate the balloon, and pull back the balloon into the right atrium. In so doing, we hope that we will enlarge the interatrial communication and the saturation improves. So this is just a picture that is showing some of the shunts that our surgeons will do for us. The most commonly done shunt is the modified Blalock-Taussat shunt, where they are connecting the subclavian artery to the pulmonary artery. In the first operation that they did to increase pulmonary blood flow was the classic BT shunt, where they connected the subclavian artery directly into the pulmonary artery. So we'll go through the questions, and then after that, I can go to the next scenario.
Amelia, are you happy for me to share the first quiz and they can complete that?
Yes.
Great. Okay, great. You guys should be seeing the next questions. And I think you can scroll down. There's about, oh, sorry, this is the wrong one. Sorry. Let me just quickly. Where's my. Sorry, everyone. Just. Okay, you're able to see that now? Great. So fire away, you will see there's quite a few questions. So we'll give you about 5 to 7 minutes to do this. So take your time to read through them, and then we'll share the answer and discuss it afterwards. So take your time. Amela, can you just check with me? This is the one that you wanted, ne? The cyanotic and shocked neonate. Okay. Okay, great. I can see you guys are doing very well. Most of you guys are now at like the question 5, 6. So we'll give 1 more minute. So please fill out your answers and test yourself.
There's no free ride this morning. Hey, Marty, making
Oh,
everyone
no.
work
Yep.
hard.
Can't just sit there. Can't just sit there and listen. The presenters had to stress, so that was also complete. But at least we won't know if you are wrong. So please don't disappear because there's questions. It's just making the learning a little bit better. So enjoy it. Okay, great. I see there's some of you that said you can't see the question. So I'm going to end the poll now, and I think Mamela can take us through it. Okay, so you should see the results and the answers, the correct answers to it on your screens. But I'm sure, Mamela, you will also take us through it, hey?
Okay. So I can't see the results. How did they do?
Okay, so in question 1, 98% said it's prostaglandin E1.
I can't see the questions now. I might have to open them on and open.
Okay, so so the first question, must I read it to you?
No,
Can you see it now?
Yes, I can see it.
Right. Sorry
Yes.
about that.
So yes, that is the correct answer. And so cyanosis, as already mentioned, become perceptible when there is the deoxygenated hemoglobin increased to 3 to 5 grams per deciliter. Pulmonary vascular marking is increased in all of the following except TGV, TAPVR, and hypoplastic left heart will be associated with increased pulmonary vascular marking. So tricuspid atresia is the correct, no, is the incorrect answer. Pulmonary vascularity decreased in all of the following except is decreased in tetralogy of Fallot, in pulmonary atresia and tricuspid atresia. So the correct answer is total anomalous pulmonary venous tear. A newborn presents to emergency with a pink right arm and blue lower extremity. So this is a child with heavy differential cyanosis. So the most likely cause for this is coarctation of the aorta. As mentioned, the dark-dependent lesion for systemic blood flow, such as coarctation of the aorta, interrupted aortic arch, and critical aortic stenosis will have differential saturation. In terms of matching of the X-rays with the description, the first chest X-ray, you can see there is cardiomegaly, there's an the outlet to the heart is quite narrow. This is an airborne string. This is a typical picture that we see in transposition of gray vessels. I think this one looks like a boot, it's obvious boot. This is a classic picture that we see in tetralogy of Fallot, but it can also be seen in tricuspid atresia or pulmonary atresia. But mostly we see this picture of polygemic lung field with a boot-shaped heart in patients with tetralogy of Fallot. Then the next picture, this is a snowman appearance. I should mention that I get a lot of consults where the patient has got a large thymus that is giving an impression of a snowman appearance. But I think if you are not sure, it's always better to check with your pediatric cardiologist.
Can you see the next one, Mamela? It's the wall-to-wall.
The next picture there is a wall-to-wall. Also looks like a box. We call it a box heart. The commonest cause of this is Epstein anomaly, but it can also be seen in other congenital heart defects like pulmonary atresia, interventricular septum. In patients with viral myocarditis as well, with dilated cardiomyopathy, they may have such a big heart. I think I've sort of discussed the matching of the chest X-ray with the diagnosis. We can move on to the next case scenario.
Perfect.
A 2-week-old term neonate born by normal vaginal delivery and is discharged same day presents with irritability, restlessness, and poor feeding. He is essentially pink, alert, and bright looking, but irritable with tachycardia and poor peripheral perfusion. His brachial pulses are easily felt, but the lower limb pulses are absent. So this presentation is typical of a neonate who's got a DAT-dependent lesion for systemic blood flow, such as a critical aortic stenosis, hypoplastic left heart syndrome, critical coarctation, and interrupted aortic arch. Another important differential is neonatal sepsis with septic shock. So usually when you see this patient, I think when I was school medical officer, I once came across a patient who presented like this, and unfortunately we kept treating as neonatal sepsis. And while we needed to start the process, but we kept saying with neonatal sepsis, the blood results were not suggested, the white cell count were low, the CRP was low, but we eventually got to the diagnosis. But I just want to say, guys, if you are seeing an infant who is shocked, but other markers are not suggestive of sepsis, please start prostaglandin E1. So you will do the usual workup as already mentioned. So in our patient, the CRP was less than 1, had blood gas from metabolic acidosis, FVC was essentially normal. When we did the chest X-ray, this is the chest X-ray that we got. There is marked cardiomegaly. There is what you call parenchymal opacification, which is suggesting that this child is having some form of pulmonary edema. So management of these patients, they usually go through the ABC, you give oxygen, you ventilate. If necessary, you maintain a neutral thermal environment, you start prostaglandin, you correct the correctable, start antibiotic therapy while you are waiting for your blood culture results. Some of these patients will not improve despite starting prostaglandin. You might have to start them on inotropic support. And then you continue monitoring and transfer to a cardiologist. We will do an echocardiography, which is diagnostic in most of the cases. This picture that I'm showing, there is a picture of a normal descending aorta. The next picture is a 2D picture that is showing narrowing of that aorta. Even on color Doppler, you see the nice blue color, then there's a changing color, what we call turbulent flow, which is suggesting that there is narrowing there. When we do what we call continuous wave Doppler, all these things my colleague will explain in his presentation. We see what there is we get 78 millimeter of mercury. Normal should be way less than 20. In most cases, should be less than 5 millimeter of mercury. You also see something that we call a diastolic tail. So this is very suggestive. It's actually just diagnostic of coarctation of the aorta. We did a CT angiogram. You can see beautiful there, narrowing of that descending aorta from the left subclavian artery. So these patients with coarctation of the aorta or interruption, the main thing is surgery. They need to have surgery. Surgeons can do resection with end-to-end anastomosis. They can use the subclavian artery to repair, or they can use bypass graft. Sometimes in neonates who are critical and they cannot go for surgery, the pediatric cardiologist may do balloon angioplasty or stenting of the arch, but most of them really, we send them for definitive surgery. The next patient is a 1-year-old boy known with tetralogy of Fallot, who's presented for surgery. Unfortunately, because of the long waiting list in our public sector, he hasn't managed to get his surgery. Now he's presenting to our casualty with severe cyanosis, having been ill with gastroenteritis the past few days. You cannot hear a murmur. What do you think is happening? This is a child that is presenting with a hypercyanotic spell. This is also called cyanotic spell, hypoxic spell, or TED spell. It's a clinical state of acutely reduced pulmonary blood flow, leading to severe hypoxemia and metabolic acidosis. It's most commonly seen in patients with tetralogy of Fallot, but can also be seen in other lesions such as pulmonary atresia with a VSD and tricuspid atresia. The clinical features are those of worsening cyanosis, irritability, rapid and deep breathing, and absence or soft murmur, absence of a murmur or a murmur that is softer than it was before. This is a serious complication that can result in neurological damage. The patient can become comatose, can have cerebrovascular accident, or can even die. So, if you remember the lesions in tetralogy of Fallot, you've got 4 lesions. There's a large VSD, there is right ventricular outflow tract obstruction, there's right ventricular hypertrophy as a result of the right ventricular outflow tract obstruction. There's also what we call overriding aorta. But the important lesions are the right ventricular outflow tract obstruction as well as a large VSD. So in terms of what causes a cyanotic spell, so if you have decrease in systemic vascular resistance, there will be increase in right to left shunting across the VSD, and the patient will become more cyanosed. So the decrease in SVR or systemic vascular resistance can occur with crying, defecation, and physical activity. Increased right ventricular outflow tract obstruction. This was always thought to be the main mechanism of a cyanotic spell. People used to think there must be some infundibular spasm because this patient, the right ventricular outflow tract obstruction can be subvalvar, where you you've got like infundibular muscle, or it can be valvar or supravalvar. So it was thought that the spasm of the infundibular muscle is responsible for the spell, but other people are saying no, the kind of tissue that the infundibulum has is not really responsive to catecholamines, is not able to go into spasm. So there is debate with regard to that. But whatever happens, there must be an increase in right ventricular outflow tract obstruction. So in terms of your management, what you want to do, you want to increase the SVR, you want to decrease the pulmonary vascular resistance. So when you see this patient, you need to be calm yourself. Then you need to calm the baby. The best way to do that is to let the mom hold the baby. She must hold the baby in the knee chest position. Because this position will keep blood in the legs and reduce pulmonary venous return, which for some time while you are trying to correct other things will reduce the right to left shunting across that VSD. You must avoid doing painful procedures. This is no time to do unnecessary things, taking blood gases at this point, because you will just make things worse. You can sedate the patient, you can use morphine. I tend to like ketamine. The reason is because it sedates the baby, but also increases systemic vascular resistance. You can give blood volume expansion in the form of saline. Remember, this patient cannot go into heart failure, so do not be afraid to give fluid bolus. You give oxygen. You can use face mask or nasal prong oxygen. You correct the metabolic acidosis. I don't like picking these babies at this point, and often I just give sodium bicarbonate even without seeing the blood gas. Some people might say maybe it's not correct, but in this case, I always just give the bicarbonate and do the blood gas later. You want to increase your SVR, as already mentioned. There are certain medications such as phenylephrine. We also use beta blockers. If you have access to IV esmolol, you can give that. Even oral propranolol, you can give. Most of the patients that I've encountered, they usually respond to just knee chest position, sedation, volume expansion, and giving bicarbonate. By the time you have to give phenylephrine, this child should be in ICU already. So that is the dose of the medication that you will be giving. So once the patient is out of the spell, you need to get this patient to the Paediatric Cardiac Center, where they will do certain things. They can do definitive surgery if their anatomy is favorable, but some patients might have to have a BT shunt. In some centers, they are doing, I know my prof, Joshi, is very good with doing this RVOT stenting while you are buying time to get the patient to surgery. So can I please have the question for hyperkinetic valve?
Right, I'm going to share it now, Mamela, but we're running a little bit short of time, so we'll probably just share it for a very short period.
And I have the questions at the end.
Okay, great. So I'm just going to quickly relaunch this.
Did you think I was suggesting maybe I continue and we have the questions at the end?
Sorry, I've already started sharing it, so maybe we can just give them a very short time for this, so 1 minute, because it's only 3 questions. I hope you guys can see it this time around. Amela, there's also questions about whether we can share your PowerPoint maybe in PDF form. Would that be okay with you after the presentation?
Yes, okay.
Yeah, thank you so much. Okay, so I see people are relatively fast, so I'm going to end the poll now and we're going to share the results. I hope you guys are able to see the results and maybe you can just talk us through that.
Okay. So this is a 2-year-old that is presenting with hypohypnotic spell. The most likely lesion, as already discussed, is tetralogy, but as mentioned, even other lesions such as pulmonary atresia and tricuspid atresia may present with a spell. Therapy, we don't use dopamine for spell. Dopamine can increase the systemic vascular resistance, but unfortunately is not selective. It can also increase the pulmonary vascular resistance. So it's not one of those medications that we use. We can use iron drops that we use. We can use what you call adrenaline, but not so much the dopamine. A test spell or blue spell of tetralogy is treated with all of the following except you give the oxygen, you get the patient in chest position, the morphine, the propranolol, the phenylephrine, and sodium bicarbonate. That we can do, but we don't give digoxin. How did they do? I don't see the results. I'm sure they
did very well. They got like more than 90% for all of these. So well done. Good teacher.
So if can't all present with a little fever, I'm gonna go fast because of time. A 3-month-old presents with little fever, irritability, shortness, breath, and poor feeding. On examination, she is irritable, in severe respiratory distress, and heavy hepatomegaly. think that that's one of the important things. The child is distressed and has hepatomegaly. She has cold peripheries with reduced pulses. So the history of fever would make you think, is this cardiogenic shock that is due to myocarditis, or is this just septic shock? So when we do the chest X-ray, you get cardiomegaly, you get features of pulmonary edema. On chest X-ray, this child has got Q waves in V1 and AVL. There is also ST segment elevation in V4, V5, V6. So what is the most likely diagnosis in this patient? So the most likely diagnosis, this is a child who's with SAPA, which is anomalous left coronary artery arising from the pulmonary artery. So the management, even before you get to the diagnosis, is the same way. The ABC, make sure that you give them oxygen, intubate and ventilate if necessary. Because initially you're not sure, is this cardiogenic shock, is this septic shock? You can give fluid, but be cautious with the fluid that you are giving. As you give the fluid bolus, you affect the liver. You start inotropes. You need to get this patient in ICU as soon as possible. Once out of shock, you can start diuretics, and you get your cardiologist ASAP. So we did an echocardiography, and what you see here is a massively dilated left ventricle and left atrium, poorly contracting left ventricle. This is the parasternal long axis there. Then we go to parasternal short axis. Again, you are seeing the ventricle that is dilated and not contracting well. Okay, when we do parasternal short axis to look at the coronaries, this is what we got. I should say on 2D, this is not the best picture to show, because it is deceiving as though the coronary artery is coming from this aorta. But the color helps us a lot. We can see that there is blue flow in that coronary. What we want is the red flow in the coronary artery. So that retrograde flow in the coronary is what suggested that this is an SAPA. Other things that we are seeing here, the coronary arteries, the coronary arteries are dilated with what looks like could be an aneurysm of the right coronary artery. I don't know if you can see my pointer.
Yes, we can.
So in this patient, because on 2D, it looked like it could be normal origin of that left coronary artery, we went ahead and did an angiogram. And this angiogram, this is a ascending aorta angiogram. You can see this dilated coronary artery that is feeding. The right coronary artery goes. I don't know if you can appreciate that there is appearance of something here. This is the pulmonary artery. So the coronary artery has dilated, the right coronary artery has dilated, cholesterol circulation has developed between this and the left coronary artery to try and feed that area of the heart that is supplied by the coronary artery. But there's also retrograde flow from the aorta down the right coronary artery all the way into the pulmonary artery. This was a very interesting patient because the coronary artery was actually attached to the right pulmonary artery, which is quite unusual. Most of the cases with SAPA, the coronary artery is coming from the main pulmonary artery. Okay, so SAPA is a rare congenital anomaly. It's also known as blind white balance syndrome. It's not that common, but you need to know about it, and you need to be aware of that classic ECG finding where you've got Q waves in 1 and AVL, as well as non-specific ST changes. Another condition that you need to remember in infants that are presenting with cardiac failure is Kawasaki. You mustn't miss Kawasaki. So Kawasaki will present with fever for more than 5 days, and of the following, they might have bilateral conjunctivitis. They will have bilateral conjunctivitis, which is non-suppurative. changes in the oral mucosa, unilateral cervical lymphadenopathy, which is non-supportive, changes in the hands and feet, as well as maculopapular rash affecting the limbs as well as the trunk. The treatment for this is to start IV immunoglobulin at a dose of 2 grams per kg. You mustn't wait for an echo to start the treatment of Kawasaki. Diagnosis for Kawasaki is not based on echo findings, but it's a clinical diagnosis. We're starting the IV immunoglobulins. We also start aspirin. We start high dose aspirin. I think I only wrote the dose of aspirin that you start once the temperature has settled. That dose is not correct. We usually start very high doses, about 20. I think there's a high end. No, I would have to double check the dose. I don't want to give false numbers, but we start a very high dose of aspirin. And once the temperature has settled, we decrease the dose to about 3 to 5 milligrams.
Dr. Libia, apologies for the interruption. We've got about 5 minutes left.
So the next patient is a patient. I think this topic is just too big. I try to cover everything. I'm going to skip dilated cardiomyopathy and go straight to this important emergency, which is called pericardial effusion, which is one of the differentials for a patient that is presenting with a large silent heart. So the patient, depending on the cause, I've often seen patients with Down syndrome coming with large pericardial effusions, and they just look stable, and there is an incidental finding when we look for ADSD. But sometimes they can present as an emergency with what we call cardiac tamponade. So the features on chest X-ray that suggests that is a large heart. It looks like a water bottle heart. How can I describe it? A water bottle that is filled. And then on ECG, the ST segment is non-specific changes really. Could be ST segment changes, could be T-wave changes. These are signs of pericardial effusion, not so much pericardial tamponade. In pericardial tamponade, clinically, the patient will be very sick with tachycardia, poorly perfused, with hypotension, elevated JVP. The treatment of this basically is pericardiocentesis, and I think all of us should be, should know how to do this procedure. Before you start the procedure, you must, if it's not if you still have time, like the patients with that I mentioned with Down syndrome that are relatively stable with massive pericardial effusion, you might have time to still send for coagulation screen, but sometimes you might not have time to check for coagulation screen as you need to save the patient. You must have your resuscitation trolley ready, IV line, cardiac monitor going, you sedated the patient, is restless, get the patient to sit up at 30 degrees. It must be done under strict sterility. Where you go, it's just on the left of the xiphoid process, just about 1 centimeter below the costal margin. You must put local anesthesia. You can use a live IV cannula. You insert the needle at 45 degrees, advancing towards the left shoulder. This can be done under ultrasound guidance. You can also do it under ECG guidance, because if you touch the myocardium, you start seeing ST segment changes. If you don't have ultrasound guidance and you are about to lose this patient, you can do it under ECG guidance. It needs to be done by the most experienced person within this procedure, but I think all of us should learn to do this procedure. And I'm also showing the pictures on the side just to direct how to do this procedure. I'm sorry I had to rush through the presentation. My topic is quite big, cardiac emergencies. There are many of them. I wish I could have gone in more detail, but for the sake of time, I hope this was helpful. Oh, before I go, there is one of our colleagues, George Comitas, has written nice articles. And this article will really help you to prepare for cardiac emergencies. You don't even need my PowerPoint presentation if you get hold of this article.
Thank you so much, Dr. Libya. This is really a huge kind of varied topic to cover with arrhythmia, structural abnormalities. And I think you did a really, really good job to give us a nice overview of everything. I think we'll definitely, with your permission, get the PDFs of your lecture out to everybody so they can have a look at things like dosages and have a look at the beautiful images that you have as well. Thank you so much for presenting this topic in a nice, concise way. Well done. Thanks a lot. In the interest of time, we're going to take a quick 3 to 4 minute break. Please, you're more than welcome to go and grab a cup of coffee, go to the bathroom quickly. We just have our sponsor video that we're going to show in the meantime. Once again, just to remind everybody, today's virtual workshop has been sponsored by EcoMed and GE. And Marty is just going to share and play the EcoMed video for us. We'll start again as soon as the video is run through.
Medicine is a calling for you, an invitation to help, to make a difference, to be a hero. But the hero's journey is filled with obstacles. The pressure to handle more cases with fewer staff resources has built up. Getting good images under this pressure is challenging, but patient care is at the heart of everything you are, and you have no intention of sacrificing quality when so much is at stake. Your patients are relying on you, and you can rely on us. You can rely on Vivid Ultra Edition. You can rely on our image quality to give you all the information you need. This portfolio has been engineered to provide superb image quality, further enhancing our legacy in cardiovascular ultrasound imaging. Our groundbreaking software development adapts to the patient's body habitus at multiple probe locations in real time and over 100 times per second, delivering our best adaptability to each individual patient specificity. You can rely on our automation to increase the speed and efficiency of exams. With one click only for strain and ejection fraction measurements in 15 seconds on average, this is our most automated ultrasound imaging system to date. You can rely on us, even for your most challenging patients. Now, with the introduction of 9VTD, even patients as small as 5-kilogram babies can benefit from breakthrough 4D technology with this compact, slim TEE mini probe. With so much riding on the care you provide, you need a partner you can rely on. You can rely on Vivid Ultra Edition.
Thank you for that, Marty, and thank you also once again just to our sponsors, Ecomed and GE. Because we're running short of time, we're going to go immediately to Dr. Samkelo Giana out in Keberga, all the way from the Eastern Cape. He is involved at Dora and Ginza, the state hospital, as well as at Netcare Green Acres Hospital, where he has his private practice, and he has a keen interest in interventions and echocardiography. I'm going to hand over to Dr. Samkelo Giana, who's going to take us through the basics of echocardiography, and this should lay a nice framework for everyone who's attending the hands-on workshop tomorrow. Dr. Giana, the floor is yours.
Sure. Can you see my screen? You're not seeing my screen yet, no?
Not yet. We
Now...
can see it now. Yes, there we go.
Well, good morning, everyone, on this wonderful Saturday morning. This is part of like the crux of our today's workshop. We're going to be talking about pediatric echocardiography. This is an introduction to pediatric echocardiography. I've got no conflicts of interest or declaration. No one is sponsoring me. I wish I had more money than that. So basically the outline of our talk is an overview, and then we're going to discuss working with your machine, the views, the measurements, practicalities of doing an echo, how do you compile your report, and basically the conclusion. Okay. So the purpose of this talk is not to make you an instant cardiologist, nor is it to exert unnecessary expectations of you. However, it's aimed at equipping you to be able to provide entry level of care for children who otherwise may have none. Never will it negate or replace the need for referral to a pediatric cardiologist. However, moreover, our aim is that it may aid in providing more timeous and early referral of children to children in our country whom accessing a cardiologist immediately is not always possible. So, for example, in Telford and colleagues in their 2020 study demonstrated that handheld echocardiography displayed excellent accuracy for detecting definite rheumatic heart disease and for detecting definite rheumatic heart disease, and the accuracy for any rheumatic heart disease is moderate with handheld echocardiography, but it's poor in borderline rheumatic heart disease. Similarly, Providencia et al. Also demonstrated that in areas with high rheumatic heart disease prevalence, handheld ultrasound offers accurate diagnosis. Therefore, we see the introduction of handheld ultrasound can have an impact in the diagnosis of rheumatic heart disease, which we know is a pandemic in our country, even in the lowest settings. So, I mean, this is also what part of this talk centers around. So, working with your machine. So this is just some of the machines that we have in the state sector, DORA. So, and I'm sure you also may have a different machine. There's a lot of different companies, as you've seen with the sponsors. Ultrasound machine, when you see it, can be intimidating at first, but the aim of this talk is to help you get around this. So, although your machine may not be similar to the next one, or the principles are all the same. However, not all machines can be used for cardiac ultrasound. For example, the linear probe that is available in obstetrics or abdominal ultrasound has a much larger footprint and much lower frequency and penetration than what is needed for cardiac ultrasound. Also, the cardiac ultrasound needs a greater frame rate than what is offered by these machines. So working with your machine, so you need to prepare yourself before doing the echo. You need to have the right right probe, which we're going to talk about, the right patient, and attach the ECG. Why is it important to attach the ECG? The ECGs, there's some calculations that your echo machine does, which are gated according to the ECG. That's why it's important to attach the ECG. And also you'll find that in some machines, in order to save your study, that it uses the ECG, recording, and also to do some calculations, then it uses the ECG as well. But this is not always possible. Enter the patient's details accurately, perform the ultrasound in a dark room, have something to distract the child, whether it's a sucker or cocomelon or baby shark, as we all know, much to our disdain. Even position the child adequately. So we always tell them, child, to put the child on the left side, maybe put a pillow on the back of the left side, but just make the child lie on its left so that to bring the heart closer to the chest and to decrease the interference of air and bone, as well as lift up the arm over the shoulder. So you're always trying to break the ice with the parents and the child. Just say, lie down as if you're lying on the beach. In our case, King's Beach. I don't know about the people in Pretoria. No. So try to sedate the child, especially smaller children. You can use chloral hydrate, intranasal midazolam, intranasal Precedex, which is a newer intervention, and just follow institution's protocol. However, whatever you do, make sure that the child awakens. An ultrasound, you should never pressure yourself. An ultrasound should take you at least 30 minutes to 15 minutes to do. Therefore, do not feel bad that if you take long to do a cardiac ultrasound. That's the whole point, is to do it properly and to do it systematically and thoroughly. So this is the protocol. It will be available with this talk that you can use for sedating with intranasal Precedex, which I'm sure other people haven't heard about before. And also with using intranasal Precedex, you can use an atomizer, which is shown on your screen here, on the right-hand side. However, if it's not possible, you can just use a small syringe with a yellow gel core cut, or with the yellow gel core and the plastic cut off, and spray that into the nostril. That will atomize your Precedex. So working with your machine, so the higher frequency probes have a much higher resolution than the lower frequency probe. So when you're speaking about the higher frequency probe, I hope you can see my marker. We're talking about the ones, this one, the 12 and the 8, where it's between 12 to 8 megahertz. The beam can only go about 4 to 5 centimeters deep, and thus it's more useful in neonates and smaller children. However, the lower frequency probe have more depth and penetration, a larger footprint, but their resolution is not as good as the smaller frequency probe. Therefore, there is more useful in older children and adults. Well, you can see also just in the design of the probe, of the cardiac probe, that it's designed just to fit in the space between the ribs, in the intercostal space, to give you a better image, which means it would be more difficult for you to use either a linear probe or the obstetric probes, which are quite bulky and would not be able to give you the same image. Okay. So for conventional imaging, the ultrasound will be in 2D mode, which is basically this button, or in some machines, B node, denoting the brightness mode and giving us a 2D cross-sectional imaging. Or the image can be transmitted in line with the motion of the organ of the heart, which is at a particular time, giving us the so-called M mode or motion mode. So each probe will have a marker on its side where, depending on the machine, it may be a knob or a ridge or a notch. And this knob is just a marker to orientate you according to the screen. On the screen, the P normally denotes the direction of the probe, and is important in certain conditions, such as congenital corrected transposition or transposition corrected arteries, just to know where exactly, and dextrocardia. Okay. To improve the resolution, you can always you can adjust the gain, which is this button here, which on your right. However, you must be careful not to overgain. In some machines, you may find that the gain is now combined together with the 2D. So turning your knob clockwise makes the gain more, increases the gain. However, must be careful to overgain, as this will exaggerate and also can produce artifacts. Or you can turn it anti-clockwise, and that will reduce the gain. Pulse wave allows you to sample velocity of blood flow right at a certain point. However, it can't sample higher velocities. Continuous wave interrogates flow across the entire beam, and color Doppler defines the presence and direction of blood flow and is used to determine the severity of valvular regurgitation. Spectral or tri-mode Doppler combines the beam mode, color Doppler, and either continuous wave or pulse wave Doppler, and is often used for complex measurements. That's that TDI button that you see. So it's important also in your machine. Some machines have settings whereby it tells you whether or not which organ is involved, whether you're doing a preset for heart, veins, and abdomen, and therefore if you choose this setting, then it optimizes the image according to this, whatever particular organ. So and you find that in some cardiac machines, they come with preset programs for adult and pediatrics, and it's better to use the pediatric one, which is more aligned to get you images if your machine does have the software. So we know that the gain is used to amplify the signal and to make the image either lighter or darker, as we said. The time gain compensations, which is that TGC that you see there on the right of the machine, which often has these buttons, adjust the brightness of the different depths to the near to the fine part of the image. So basically, it compensates for the time it takes for your ultrasound beam to come down from the probe onto the skin and coming back. So it compensates for that distance it takes for the ultrasound to come back to the machine, and gives you a clearer image in that way. Focus defines the area of the image where it is optimized. If you've got a special region of interest, then you adjust the focus to that specific region of interest where it negates at least some of the fallout. You use your distance calipers to allow different measurements within the different areas in the ultrasound image, whether you're measuring the size of a valve or you're measuring the PDA, then you use those measurements, as well as calculations. Some machines say calculations, some machines say measurements, where you use to measure function of the heart, to calculate the left atrium to aortic ratio, and so on, according to what's available on your machine. So when we are Dopplering or sampling whatever valve or lesion that we're sampling, it's always important that when you're doing your Doppler, you just measure the distinct area, and you must leave out the beard, as it says here. So it's always important to just measure the chin and not the beard. So always remember Bart-Simpson, and you must remember Bart-Simpson's pens are always at the bottom. So in color Doppler, all color Doppler tells us is just the direction of blood flow. It doesn't tell us whether it's oxygenated or deoxygenated blood. So blue is away from the probe and red is towards the probe. So if you always forget this, because sometimes it's important to see where your color probe is, because sometimes you can invert this, and maybe someone else was using your machine and they haven't inverted the Doppler. So therefore, you must always remember that Bart-Simpson's pens are always at the bottom. You can always get aliasing flow when there's high velocity flow, and you can reduce the aliasing flow by decreasing the frequency or changing the scale. The tissue Doppler is used to measure myocardial, or rather than blood velocities, allows us to assess systolic and diastolic myocardial function. Here in the 4-chamber view, you place your cursor at the junction between the ventricles and the atria and over the interventricular septum, especially and on the lateral wall of the left and right ventricle. Especially if you want to see if there's any diastolic dysfunction in children, like your Duchenne's muscular dystrophy, then you can use the tissue Doppler just to help you and aid you in the diagnosis. Freezing and using the trackball, which is that round part. Most of the machines have trackballs, although I see now the latest machines come with touchpads, but it allows you to see what's going on in the machine, especially sometimes you find the child is moving a lot, or you find that because the child is tachycardic, then you can't see clearly, then you have to freeze the image and then scroll. And then it's important, of course, to acquire or store your image. That's why it's important to enter the correct information so that you can always go back for future reference and also when you're compiling your report. Some centers are fortunate enough to have a central PACS where once the information has been recorded, it's then recorded onto central PACS. If you're not in the case, it's always important for you to keep accurate electronic or written records. So this is your screen where you see you normally have the name of the patient. It gives you what in what imaging modality where your gain is set, the frame rate, it's 25 millimeters per second. And then the orientation of your cursor. Then you have the cursor running in the middle. That green line represents the ECG. Here you can see there was no ECG attached. Then it does allow you, most machines will allow you to do left to right invert, up down invert, and this is always a debate between the North and Northern America and Europe, and in our case, Joburg and Cape Town and Eastern Cape Durban, whether or not whether you measure, you take pictures of the heart up, down, up, as long as you can pick up the lesion, that's the most important thing. So holding the probe, you hold as we said, the patient must lie in the left lateral decubitus. So the probe is like a surgical instrument. Therefore, you must hold it gently. And firstly, firstly, the probe is one of the most expensive parts of the machine. And also to keep it stable, you must hold it like you're holding a scalpel, like a surgeon holds a scalpel. You never hold the scalpel at the end you never hold the scalpel at its end, you hold it close. Therefore, you hold it close to the blade and you anchor and you stabilize by anchoring your 4th and 5th finger onto the patient's skin. So avoid unintentional movements, learn to be gentle and moving on the axis of its position as if you're dissecting in theater, as you would be doing, just to get proper nice pictures and nice slices of the heart. So as we said, 6 steps to get a good enough gel. So use enough gel. Sound waves that normally bounce off the air and fluid interference, therefore no image can be created. You can try and warm up the gel if you've got waves, because especially in the smaller children, you'll find that the child been lying down. Rest your hand on the patient. The more stable your hand is, the more stable the image. I know sometimes this is not possible. We get a squirmish preemie who's in an incubator. Your hand is there reaching out through the window of the incubator, but try and stabilize the child, even if you have to put a cloth against the wall of the incubator and then tilt the child slightly. And you can even get someone to hold the arms, or even the trick that we do sometimes, you can just take the arms, put them against the baby and wrap the napkin napkin on the baby's hands just to stop the child from moving. Again, with patient positioning, I've been caught in this awkward situation once where, because you can, if a child is breastfeeding, it doesn't mean that you can't, there's no way, because normally it's easier if the child is being bottle fed, you can just ask them to give the bottle. But if the child's being breastfed, you can ask the mother to please just come closer to the baby and try and breastfeed, and obviously further away from you. I once asked the mother to just hang her breast, and the mother told me, please, doctor, my breasts do not hang. So just be careful, but try and get in any ways just to get the best image. So optimize your settings as we've discussed before, and be patient. It may take you a while to find the perfect positioning, and it doesn't mean that just because if you are using an 8 probe, it doesn't mean that if you are struggling to find, if you're using a 12 probe and you're struggling, doesn't mean that you cannot use a bigger probe just to get better imaging. You don't need to be stuck, but preferably, as we've previously said, use the certain guide for a certain probe for a certain size of patient. Most importantly, be respectful, preserve patient modesty, and wipe away the gel when you are done with your echoes. Okay, so examining the heart echocardiographically, we talk about the views. So we describe the different positions according to the axis of the heart and not the position within the body, because obviously this is because you can get the heart in different positions, dextrocardia, levocardia, where it's not in, or in fact you may have dextro position of the heart. So we use the positions of the view of according to the axis of the heart to describe the different position. So we prefer a segmental approach, starting with the situs and laterality are determined, especially in the newborn. Then each structure is examined and described from the systemic and pulmonary venous return through the atria, ventricles, and great vessels. So as per the morphological characteristics, solitus, the normal anatomy with the liver on the right, spleen and stomach on the left, right atrium on the right, and left atrium on the left, and the atrial septum with the flap of the PFO to the left and the eustachian valve to the right. Identifying the atrial appendages and the atrioventricular valves belonging to the appropriate ventricles, the tricuspid valve, which has 3 leaflets and lies more to the apex and has septal attachments and associated with the morphological right ventricle. The mitral valve, which has 2 leaflets that are attached to the lateral wall of the ventricle, of the left ventricle by 2 papillary muscles and no septal attachment. It's associated with a morphological LV. The RV is heavily trabeculated and has a moderator band. The left ventricle is smooth, and the aorta rises from the left ventricle, the pulmonary arteries from the right ventricle. So in the long axis view, it's normally done in the 4th intercostal space. You can see there in our baby. The notch is pointed towards the right shoulder. Here we see both the mitral valve and the anterior and posterior leaflets. And then we see the aortic valve, the LV outflow, the aortic annulus, the sinus of valsalva at the bottom, sinus of valsalva, as well as the ascending aorta. And then most importantly, the continuity of the mitral valve, continuity of the aorta with the mitral valve. The interventricular septum, which you need to describe its thickness, and then determine the size of the aorta, the ratio of the left atrium to aorta to determine hemodynamically significant lesions, the coronary sinus, and RV inflow, which we see in picture B, and the RV outflow, which we see in picture C. So as you can see in this patient, we can see as we're measuring the aorta to the left atrium ratio, and here we've got an aorta of 12 and LA of 24, LA to AO ratio of 2 basically, whereas the normal LA-AO ratio, at least we expect it to be about 1.5. And you can see and can appreciate in the video as well, in the video that you can appreciate as well that that the aorta is small and that the ratio of the left atrium there, and the left atrium is dilated. So in the long axis view, you can use it to determine the left ventricular internal diameter and diastole, left ventricular internal diameter and systole, and give us the volume, and look at the aortic sinus, sinuses of valsalva, and the tubular junction, and ascending aorta, especially in those children with Marfan syndrome or some children who've got bicuspid aortic valve and may get AS from this. So in the parasternal long axis view, we're still looking at the RV inflow plane. When we angulate the transducer posteriorly, the tricuspid valve can be seen, as well as the RV and RA. In this case, we can see that the RV in this child who was a repaired tetralogy is dilated, and the tricuspid valve is normal, and you can see there's the left atrium. And then here we can see in the posterior, in the longer axis view, RV outflow picture, we can see just angulate the transducer anteriorly, and the RV outflow tract can be seen, including the pulmonary valve. Here you can see your tetralogy of fellows. You can see here the pulmonary stenosis, if there is any pulmonary stenosis. So in the parasternal short axis is achieved by rotating the probe 90-degree clockwise, and then now you see that the probe is looking towards the patient's left shoulder. And here you can evaluate the heart chambers, semilunar valves, AV valves, and the coronary arteries. Let me just wash my hand as I'm rotating there. So you see that my little finger is always resting on the patient. Start off in the long axis, and then slowly on the axis itself, you can see that we are rotating now and rotating towards the left shoulder. And then if you're looking now posterior, then you can see the apex, which we'll talk about later. Okay, so in the parasternal short axis, these are the views that we're seeing. We see in A, we see the standard plane where we see the right atrium, right ventricle, pulmonary artery, and left atrium with the aorta in the middle. It's also important to report how many leaflets the aorta has in this position, if there's a bicuspid aorta, a tricuspid aorta, and then also at the level of the coronaries, you can see if there's any dilatation of the coronaries or the position of the coronaries, as Mamaila has already demonstrated to us in the child with the Al-Kappa. And then also at the level of the mitral valve, and then finally the papillary muscles in picture E. So you can see in that video, the practical that we're talking, in that picture, the practical that we're talking about. You can see right atrium, right ventricle, pulmonary valve, and then going out into your right pulmonary artery and left pulmonary artery, or we say sometimes those trouser pants. So in this case, in this little one, same 15-year-old that had been repaired as a TOF, you can see that the child's pulmonary valve, you can't visualize the other leaflet. The right ventricle is dilated, the tricuspid valve you can make out. There's a tricuspid, there's the aorta in the middle. Then we play the next video, we're seeing both blue. Remember, blue is away and red is towards. And here we're seeing the blood going out of the right ventricle to the PAs, but some of it is coming down again. So in this case, this child had a tetralar fellow repair and has now got free PR with a dilated right ventricle, which we can see in this picture.
Oh, so come on, bro.
So in the parasternal short axis, most importantly, as you said, we can assess the presence of a PDA, assess for the evidence of pulmonary hypertension. So in this video, you can see it starts off in the long axis. You can see this is the aorta to the left atrium, quite a dilated left atrium and aorta, LAO ratio of 2.4. And this is a beautiful example that you're not going to see very often, where you see the main pulmonary artery, right pulmonary artery and left pulmonary artery, and a huge PDA coming out of the left there, what we typically call the tripod sign. You can see we measured the PDA here as about 5.94, but this patient we couldn't close with percutaneously, and the PDA was actually 10 millimeters when the surgeon did the ligation. So it's very important for you to This is one of the very important views where we can get a whole lot of information from the parasternal short axis. Again, similarly, as Mamaila has said, remember, blues are away from the probe, red is towards the probe. And in this case, we can see that, whoa, these coronaries are not red. They're not going away from the probe. They're not going, towards the probe, but rather they're going away from the probe, and which is a patient. And then you can see in the other picture, there was actually an abnormal left coronary. They're giving away the answer. Marty, can you go to this call, this quiz?
Okay, let me see if I can quickly do this one. Sorry.
So this is so this quiz is based on this picture.
Let me just see if I can find the right one. No, it's not that one. Sorry. Maybe just go through the discussion. Sorry, Sam. I can't find the correct one now.
Oh, it's fine. Anyway, I gave it away as well. So in this case, you're asking 2-month-old presented with heart failure with a big heart. What was the question? Nothing is wrong. The problem is an inexperienced operator. There's pulmonary hypertension. Number 4, anomalous left coronary arising from the pulmonary artery, which in this case, it was an Al-Kappa, which we can see there. Okay, so in parasternal short axis view, we see papillary muscle view. The left ventricle is round and concentric in shape. On the right ventricle is D-shaped and crescenteric, if you want to say. I normally say when I'm explaining to the parents that you can see that the left ventricle is round and donut shaped. And that's the normal shape of the left ventricle, and they shouldn't exchange shape. You can assess the papillary muscles and the presence of a cleft. A true mitral valve cleft will be directed towards the septum, the interventricular septum. Okay, can see there. In this case, you can see this patient, the young man who had a surgical procedure done at 2 months when it was blue. There's any abnormality in the image. Please choose the answer in this quiz.
Okay, I'm going to share. Hey guys, we are falling down. We only have 40% of you answering. So let's see if we can get at least 60%.
Hungry.
They're hungry now.
They're hungry.
Okay, good. I'm going to end the poll. Well done. Got half of them. And I'm going to share the result. Okay, so I don't know if you can see that.
Excellent. They're not too hungry.
Okay. Hungry, but not hangry.
Not too hungry. As you can see, this is a tetralogy of fellow, which has been repaired, as I said in the history. It's very suggestive, but you can see that the shape of the left ventricle remains, but the right ventricle now is very large. It's almost looks as even bigger than the left ventricle. Due to that free PR is similar. It's that same patient. So the apical 4-chamber view, again, now this is in the 4th intercostal space. You can see right below the nipple. And here you can see the pointers pointing towards the left. You can then tilt your probe according to the different views that you want. Initially, most of the time when you're looking straight, you get the 4-chamber view, and then when you tilt looking anteriorly, looking posteriorly a little bit, then you see the left ventricular outflow tract, you see the aorta, and then it's also possible to see the coronary sinus as well as to see the pulmonary veins. So 4-chamber views is perfect for identifying the anatomical right and left ventricle, where you're able to identify the mitral and tricuspid valve, the atria, interventricular septum, interatrial septum, pulmonary veins, and the moderator band. So in this question, we want to ask you in this 4-chamber view. I'm gonna go now, we're just showing you the different 4-chamber views. Okay, and the questions are, do you have the questions for this one with the different hearts? So which chamber is enlarged between, which chamber is enlarged in A, in heart number A? And then which chamber is enlarged in heart number B?
Oh dear, Sam, I've only got one.
Yes. Okay, that's
I've only
fine.
got one question, so maybe we can do A and then discuss.
Yeah.
Is that all right?
Okay, that's fine.
Okay, so we've got about 50% of answers. So let's give them 2 more seconds. Okay, great. I'm going to end and share. People are very unsure about this one.
Okay, so 40% of you almost said the right answer, yes. So it's the right ventricle, which is enlarged. It's again the same patient with tetralogy of Fallot, which has been repaired. So just
I can do another one for B if you want.
okay, we can do another one for B, that's fine. So in this case, in A, we can see that the right ventricle and the right, so the right atrium and the right ventricle are enlarged, and almost are bigger than the left atrium and the left ventricle. So this is the same patient with the tetralogy of Fallot post repair, who is now 15 years old. Okay, in B, we want to know which chamber is enlarged.
Is B also? Oh, yes, sorry, now I can see it. Sorry, and I didn't give them the option to choose two. Okay, I'm going to end the poll and then you can discuss.
Good. So most of you got this correct. So this is, in this case, it's the left ventricle, which is enlarged. And then this picture B is linked to the last lesion, where we can see that, I don't think we'll do a poll for that one, Mati. But we can see there's quite severe mitral regurgitation. And this is severe because it's now reaching even the pulmonary veins, which you can see there. So this child had quite severe MR from a cleft mitral valve. Okay, apical 2-chamber view. So if you rotate the 60 degrees from a apical 4-chamber view, then you are able to examine the left atrium, including the left ventricle, and including the mitral valve. So you're seeing there. 4-chamber view. It's one of the most important. It tells us which ventricles are which ventricle is where, as well as the atria and which atrium is associated with which ventricle, the presence of any defects in the interventricular septum as well as in the interatrial septum. In most of the time, you must just be careful with the defects in the interatrial septum. We normally do not report them in the 4-chamber view because sometimes, especially in older children, you get a lot of fallout in the 4-chamber view, and you may think that there's an interatrial septal defect or the ASD, and when there's none, which when you do your subcostal view, then you find that there's no ASD. Okay, in this case, you're seeing a lesion. There's a defect, which you see in the 4-chamber view. So in the 4-chamber view, you're seeing both the tricuspid valve, and I'm going to give you a clue to your answer here. You can see both tricuspid valve and mitral valve, and they're both in the same level. What do you think is the lesion here. A, an inlet VST, B, apical VST, or C, multiple VSTs. So an apical, so classify VSTs according to their region, whether it's located close to the membranous septum or the valve inlets. In this case, we can see both inlets, tricuspid valve and mitral valve. And then if it was apical, it would be at the apex. So what VST do we think this is?
I don't have a poll for that, hey?
You can't do that one for me now. Okay. So this is an inlet VST, which we're seeing in the 4-chamber view. So if it was a perimembranous VST, we'll see it more in the 5-chamber view. So this is an inlet VST, which is quite significant because we see that it's causing also dilation of the left ventricle and the left atrium. So then the apical 5-chamber view. So in the 5-chamber view, we're seeing here can tell you about which vessel, where the aorta is committed, as well as the presence of the VSD. Just getting the video to play. So here we see that there's 50% aortic override. This aorta is not committed to neither the left or the right, but rather is receiving blood from both sides. And then, as we said, remember I said blue is away from the probe and red is towards the probe. And you can see that the color here is blue more. So therefore, it's a right to left shunting. Okay. Subcostal view, here the patient lies supine and the probe lies perpendicular to subcostal 4-chamber view, and then a subxiphoid position in line with the sternum. Here we image the inferior vena cava, the right atrium, right ventricle possible, and the left atrium. Some children, like in an older child or like in your teenagers, it may be difficult to see in this position. Then you can ask them to flex their legs so that you can see clearly, especially when you're doing the other subcostal views. So in the subcostal view, as we said, we're looking at the IVC, which can tell us about the volume status of the patient, which Marty wants to know about, continuity of the IVC to RA, pulsatility of the abdominal aorta. And then also, so in subcostal view, then we go looking from, when you look more towards the right patient that you see the IVC, then you tilt within the same axis and look more towards the left, and you're going to see the abdominal aorta. Then now to rotate, and you're going to see now subcostally, as I'm doing, then you can see that ekbizani, my pinky is always on the patient, you're holding it steady, patient is not moving as well, but obviously it's not always the case. So in this case, this patient can see that the IVC was dilated, and you can see there's the pulsator abdominal aorta. And then subcostally, we can see this patient, sorry, apologies, I didn't anonymize that slide. This patient had an interatrial septum, and then subcostally here, we see this patient with a huge pericardial effusion. In the subcostal 4-chamber view, the most important thing, as we said, saw in our video, we start off with the probe longitudinal, where we look at the situs, we look at where you see the vertebra and the position of the IVC in relation to the midline and the aorta, and the position of the liver and the stomach, if you can, whether to tell us it's situs solitus, situs inversus, and basically the lateralization of the organs. It's important to have your probe on the patient. As you can see here, patient not being scanned, but rather the sofa. Okay, in the suprasternal view, it's always important to position this patient, to extend the neck so you can see the whole aorta. Otherwise, you can easily miss a patient with coarctation if your patient's neck is not extended appropriately. So in the suprasternal view, we start off by looking at the midline, looking a bit with your probe tilted a little bit towards the left, and you can see the innominate, left common carotid and left subclavian, the RPA in the middle, and the descending aorta. So this was a little one who presented to us at 2 months. Also, picked up initially, and you can clearly see that the ascending aorta goes and then it tapers down, and you can clearly see that there's isthmus there, and there's aliasing flow, which indicates turbulence. And then when you measured that aorta, you could see that it starts off at 4 millimeters, goes off to 7 millimeters, and the narrowest part, which is the coarctation, was 3.4, with post-dianetic dilatation at 7 millimeters there. And again, which Mamela has shown you, you could see there's a correlation here. This patient had quite a marked gradient of 92. Normal gradient is at least less than 20, and above that, we consider we need to rule out coarctation. In this case, again, which is pathognomic for coarctation, this patient on the Doppler tracing had a diastolic tail. So the diastolic tail is that flow that you're seeing there. So suprasternal views are important because this is the video, it's related to that, but this video is just showing my age.
Remora. Where did she put it? She knows I like my Remora. Now she hides it.
Remora. She's so rich and creamy. You'd expect to find it in the fridge.
Andy, there's no Remora in the fridge.
It's not inside, it's on top.
It's not inside, it's on top.
Remora, top of the coffee creamers.
Okay, so this is in relation to the next slide. So here I did a suprasternal view, and Andile was with me during this day. We were doing our busy neonatal clinic on a Friday, and I was like, there's really something on top here. It's something I can't really tell what it is, and really was not inside, but it was really on top. And was wondering what could I be looking at. Was definitely, you can see there is the aorta there. It's going out. There's not really any narrowing, but there's this something on top. And then I took another look. And then lo and behold, you could see a whole supracardiac TAPVC with the vertical vein going up and joining the pulmonary veins and going to the right side. And then when we went and looked again at the subcostal four-chamber view, you could actually see that there's actually no connection with the pulmonary veins to the left atrium. So it's always be patient, be patient with yourself. If you're unsure, go back, look again, go back to your views, because you are most likely to find the answer then. Okay, M-mode echocardiography, as we said, it's in line with motion of the heart. So here we can use it to measure the function of the heart. We can use it either in 2D in long axis view, in long axis view, or in the short axis, and we examine the function of the heart. So here we can see this child's heart was literally rocking. There was hardly any movement. This is a little 10-year-old girl presented to us with myocarditis following an influenza infection. You can see that the heart is hardly moving. And then when we did the function, which you can see in we did that in long axis. So we measured the left ventricular internal diameter. So most of your machines will start with the diastole, left ventricular internal diameter and diastole, and then you go into left ventricular internal diameter and systole, and that will give you the function. In this case, she had an ejection fraction of 23%. Really would accept ejection fraction of at least 50% and above for that child. And you may find that in some machines, the calipers may be placed inwards, depending on what the setting is of your machine. Okay, in M mode, you can also use just by measuring the samples and measuring the muscle size, and then being able to differentiate and tell us what the function is in that way. In children, you use normal values the normal values for the different, for example, if you want to know if your aortic root is small, so if your aortic valve is small or your pulmonary valve annulus is small, we use Z-scores. I've put some pictures here of the apps that are available. This one, the one on the blue screen is PeedZ. It's an app that's commonly used in Cape Town just to plot the different sizes and say, for example, you can't just look at a coronary and say that it's big. You need to plot it according to the child's weight and height. Here we often use this app. It's called CardioZ as well. That's also free, available on the store to plot. But if you don't have access to the apps on the phone, you can also use Parameter Z, which is also uses Z-scores according to the weight and height to plot whether or not it's normal, especially if you want to know that if the aortic root is dilated and so on, if there's mitral valves, if the pulmonary arteries are hypoplastic, then you want to use that. So measuring the pressures, pulmonary pressures, you can measure this inversely by measuring the pulmonary regurgitation and also tricuspid regurgitation. When you get the TR value of whatever TR value that you get from the tricuspid regurgitation, if there's dilated IVC, which is collapsing with respiration, which is not, if it's not collapsing, if it's collapsing with respiration, then you add 5 millimeters mercury to that. If it's not collapsing with respiration, then you add 10 millimeters mercury to that, and that will give you an inverse relationship of the measurement of the pulmonary pressures. So you can measure valvular pressure, especially it's important to measure it in alignment of the valve with using continuous wave. The problem is that you can't use pulse wave because there's a certain limitation in the amount of measurements that the pulse wave can do. And also when you're measuring the pulmonary, whatever valvular pressure, you determine the morphology of the valve, measure the valve annulus, estimate the peak and the mean gradient. For example, if the mild pressure gradient across the pulmonary valve, sorry, this is also not anormatized, then we accept in the pulmonary valve peak mean pressure gradient of between 35 to 40 and a velocity of less than 3 meters per second, and moderate to accept a pressure gradient of 40 to 70, velocity 3 to 4 meters per second, or severe, more than 70 millimeters mercury, or velocity of more than 4 meters per second. In this case, you can see the velocity was 4.7 meters per second. So this patient had quite severe pulmonary stenosis. So measuring aortic stenosis is similar to pulmonary stenosis, can occur at the level of the valve or above the valve or even below the valve. And if it's below the valve, it can be muscle bundles or it can be a membrane, and can be graded as mild with a peak velocity of between 2 to 2.9 meters per second, mean Doppler gradient less than 20, moderate with a velocity of 3 to 3 meters per second, mean Doppler gradient of 20 to 39. And if it's severe, with a peak gradient of 4 meters per second or a mean gradient of more than 40 millimeters mercury. So valvular AR, we measure AR by measuring the pressure half time of the valve, and we accept the pressure half time of more than 500 meters per second with no flow reversal in the descending aorta. In this case, there's moderate valvular AR. If you've got a pressure half time of 200 to 500 meters per second, you can see where your calipers are. They start at the top of the regurgitation going down, and then severe pressure half time is less than 200 milliseconds with flow reversal in the descending aorta. So how does this flow reversal we're talking about look? As you can see there, same patient, there's reversal of flow. The flow goes to the descending aorta, but then returns and comes towards and becomes red and goes towards the probe. Okay, in this patient, it was a nice surprise. Child had been repaired as a coarctation earlier on in neonatal life, and found that he's got this quite a tight gradient across the mitral valve. And if there's one thing you're going to see in the mitral valve, if there's mitral stenosis, it always gives you this candlestick appearance. So, and then we grade mitral stenosis according to the severity. If it's at more than 12, that's severe mitral stenosis. And in this case, you can see that this patient also had a ridge below the aortic valve, so it had subaortic stenosis as well. And really, we don't really make these things up. You can see for yourself, this patient had both the lesions. You can appreciate the aortic valve, the subaortic muscle ridge there, and then you can see, remembering that the heart is a three-dimensional structure. In this case, I'm sure this membrane above the mitral valve ring, you may see it better if there was 3D echocardiography. And then you can see in this child with the mitral stenosis, you can see that the peak mitral valve gradient was 19 and the mean gradient was 11, and this child had surgery expeditiously. Okay. Okay, and then this is a feast of cases. So here we see this little one, I think she was 7, she presented to us with a history of weight loss, being very ill, and you can see that there's a huge pericardial effusion. This child was in tamponade. Why do we say that this child was in tamponade? Because we can see that the RA is collapsing and RV is collapsing, and you've got a dancing heart. Okay, and then here we then had started, put our catheter. You can see our catheter there, coming in there, similar to the picture that Mamaila showed. And then we could already see that the heart was already starting to look better. Once now it started draining, there's less collapse of the right atrium and the right ventricle. So in this one, we had a 4-month-old presented with a rash and peeling hands and a fever which was persistent and with red peeling lips. And then you wonder what on earth is the echo showing. I think Mamela gave us a clue, and I don't think you really need to be a genius to see this. You'll see that the coronary is quite enlarged, and this patient had quite a bad Kawasaki. When we plotted this coronaries, it plotted on +5 on the Z-score for the child's weight. Sorry, in this one, this child presented as a neonate, was a blue baby. You can see that there's 50% aortic override. In fact, you cannot even make out the septum. This one had a single ventricle. And then you can see that there was tricuspid atresia and with a large VSD, and the child had been repaired. That structure that you're seeing there at the bottom, that round structure, is the fontan. Okay. And here we're seeing again another case with 50% aortic override, which I wanted to show you then. Okay, you can see 50% aortic override, the color being the shunt being right to left. Okay, you can see how thick the RV is in this case, in this patient with tetralogy, with right ventricular hypertrophy. And we can see here, there's multi-level pulmonary stenosis. The pulmonary valve, as we said, you need to interrogate it. We can make it out as thick and doming. And then also there's also muscle bundles just above it. Okay. As you can see, children do move, and this child had 50% aortic override. So do not feel bad if your child is moving and you're struggling to get pictures. So in this patient had enlarged left atrium and left ventricle and LAO ratio of 1.9 as well. And that was all from that VSD, which went on to close percutaneously. So this case is an interesting case, which was Shame I didn't give you Marty this one, but it was an interesting case, which was in Mthatha. Child had quite a large left atrium and left ventricle, and you could see that the valve was the mitral valve was not collapsing. This is quite a nice example of it. You can see that the mitral valve leaflets are thick and the hockey stick shaped, in keeping with rheumatic heart disease. So the current application in this case, we're not expecting you to do a report like a cardiologist. It is to create a functional report with two-dimensional imaging, address the connections, anatomical relations, include the important negative findings and positive findings, evaluation of cardiac function, evaluation of the fluid state or responsiveness, especially in ICU, hemodynamics of the patient and pulmonary hypertension, the presence of a pericardial effusion, and tamponade, evaluating transitional circulation, and the presence of a PDA. So a recap, this is just some of the imaging that you start off with your long axis, parasternal long axis, parasternal short axis, and then you could do a parasternal, the apical 4-chamber, and you do subcostal 4 chambers as well. And don't forget to include the 5-chamber. And then subcostally also you can look at the inferior vena cava. And then for us, we want a 4-chamber. We want you to look as well and describe the situs, and also to look where each grade vessel is coming from, and they're not transposed. So this is just a recap. So here you can see that the operator is starting off you can see in the long axis, left atrium, left ventricle, sorry, left atrium and aorta, left atrium to aorta ratio. Then we do the function. You can see, put color flow, looking for any MR, AR. And remember, blue is away from the probe and red is towards the probe. And then now we're doing the 2-chamber, we're looking at the RV inflow. And you can see that there's a bit of regurgitation there in the tricuspid valve. And then measuring that RV inflow gradient. Now we're looking at the RV outflow gradient. See, there's only a little bit of PR. And the pulmonary valve gradient of 3.5. In the short axis, we're looking at the LV and the RV. Now seeing the papillary muscles. And then the short axis again, we're seeing the RA. Now we're seeing the RA, RV, and going to the pulmonary valve. Again, you can see the tricuspid valve regurgitation. And also in this view, in the short axis, it's also where you're able to see your ASD as well. Pulmonary valve gradient is 2 there. And then now 4-chamber view, seeing a nice right atrium, right ventricle, left atrium, left ventricle. And you can see the LVOT gradient. And then we can still see the TR that he's demonstrating there. As you can see, even on that previous picture, that still you could see that it looked like there's an ASD, but there's no ASD, which you see now when you're doing your subcostal view. So subcostal view and the short axis are the best to look for an ASD, but we hardly report. We can see ASD in 4-chamber, but it's best to report it there. Then they will demonstrating the pulsatility of the aorta, and then looking for any coarctation and measure the gradient of the aorta, which we're seeing now, of the descending aorta, which we see is 7. So this is a goodbye quiz. We wanted to know what percutaneous intervention has been performed in this patient. Is it a PDA occlusion with the device having embolized, VSD devices in situ, or is it stent placement? Then
Hey, I've launched it. It's the last one, guys. We promise before lunch. Okay, I'm going to end the poll. I think people struggled a little bit because that video wasn't playing.
Awesome. I haven't played now as long. Just see. It doesn't want to play now.
So are you able to play it now that I've stopped sharing?
No, I can't play it still. I don't know. Let me go back and I can't actually move anything. Let me just see.
Okay, now we can see.
Am I able to run the poll? And let's see.
Let me just quickly share the result again. Okay. Okay, so you can see that, Sam. So 50% said it was a VSD device in situ, 25 said PDA with the device embolized, and 25 said stent placement.
Okay. Yeah, so this was a VSD device. So this is a device that we closed successfully percutaneously. Thank you so much, Mati.